give your foremost. to find somebody for them. Well, not no. I mean, I told them where, you know, I said, well, you can try this university, try that, try the other. I didn't give them names. I just guided them to say, look, microbiologists our medical microbiologists or clinical microbiologists is not the same as in the US. So try to avoid people from the US because they don't have clinical microbiologists. Microbiologists are straight scientists.
Your mic.
Morning, yeah. I don't know. It should be no. It's Trinidad time. So that's our Jamaica time. Remember, we're an hour behind Trinidad. Yeah. Where are you? You're in the department?
Come in. It's a nice one. Yeah. Inside there, I could not get the proper background screen because of the light. Using this login, right? I will give you credential of co-host so that whoever comes monitoring or muting the audio, and I will give the list of people, you will transfer them to panelists like that. Okay. Yeah. Hello, everyone. We are going to start very soon. Please stay tuned. Thank you. Hi, everyone. We're going to start very soon. Please stay tuned. Thank you. Good morning, everyone. I am happy to have participants from Trinidad and Tobago, all Caribbean region, Latin America, India, and Nigeria. I extend my good morning, good afternoon, and good evening, everyone. Thank you very much for joining with us. Myself, I am Dr. Chandrasekhar Unkal, lecturer in medical microbiology, Faculty of Medical Sciences, the University of West Indies, Trinidad and Tobago. I'm chairman for this organizing committee for CACM 17th Annual Symposium. Before we move forward, I have a few housekeeping notes to make. First of all, I request everyone please keep your mobile on silent mode, and I seek your cooperation in making this conference a fruitful event. Also, please feel free to use the question answer option at bottom of the screen to write your questions and comments. Thank you very much. To begin with, dear all, the National Instrument of Republic of Trinidad and Tobago, the steel pan, which is a musical instrument indigenous to Trinidad and Tobago, whose early evolution dates back to 1930s. Here, we have two budding panmans to present national anthem of Trinidad and Tobago. May I request everyone to stand for the national anthem? Thank you. What happened with that? Okay. Awesome. Thank you very much. Now, to begin this program, I am pleased to invite Professor Patrick Akpaka. Professor Patrick Akpaka is professor in medical microbiology and head of the Department of Paraclinical Sciences, Faculty of Medical Sciences, the University of West Indies, St. Augustine campus, Trinidad and Tobago. He obtained his MBBS degree from University of Nigeria and Doctor of Medicine in Microbiology from University of the West Indies, Mona campus, Jamaica. Professor Akpaka is also a consultant in medical microbiology with NCRHA and TRHA, Trinidad and Tobago. He has been actively involved in teaching and research at the University of the West Indies. His research interests includes molecular epidemiology of multi-drug resistant bacteria, infection of public health interest, and published more than 80 research papers in national, international journals with high impact and citations. Professor Akpaka is also actively associated with several national and international scientific organizations, including ECCMID, ASM, ISID, IDSA, and so on. Professor Akpaka is also one of the founding members of Caribbean Association of Clinical Microbiologists, CACM, and currently he is president of CACM Trinidad and Tobago chapter. Having introduced in brief about Honorable Professor Akpaka, I request Prof. Akpaka to introduce about CACM and formally welcome you all. Prof, over to you.
Hi, everyone. Let me sincerely, as I welcome all, to apologize for some technical hitch that we are having. I don't know, we're getting some echoes. I guess we would have to mute either the live streaming, because this program is being streamed live on the YouTube and the Facebook. I'm getting some echoes, and I sincerely want to apologize for this technical hitch. I don't know if our technical team can help us. So if anybody has two mics on, if you have two mics on, please can you mute the mic so that we do not get the echo. If you have two mics on, please can you mute the mic so that we do not get the echo. Yeah, so please mute all your mic if you're not speaking.
Prof, excuse me, give me a second, please. Prof, may I?
All right. I think it's much better now.
Yeah, yes, Prof. Now it is okay.
Very much. You can all hear me. So once again, I want to warmly welcome all of you from wherever you're tuned today, either from India or either from the Latin America, the Caribbean. It really gives me great joy to welcome to this, our 17th annual symposium and general meeting. Now the CACM in short, which is the Caribbean Association of Clinical Microbiologists, was inaugurated in 2004. It was a vision that was shared with some of us by one Mr. Sunat, Kerry Sunat, who was then working with Wyatt Pharmaceuticals. He came and shared his vision with Dr. Alison Nicholson, who is still with us today as one of our founding members. And look at where we are today after 17 years, because the CACM He has this vision, you know, to not only share, not only to train, not only to share information, train skills in any area that is related to microbiology. And today we have several members all across the Caribbean. And it gives me great pleasure to welcome those from Bahamas, those from Barbados, Dr. Delores Lewis, those from Jamaica, the team from Jamaica, Dr. Allison, as I mentioned before, Dr. Rodriguez, and to also welcome those from Trinidad and Tobago, you know, that is hosting it this year. This is the second time we are hosting this conference virtual. Last year it was in Jamaica and it was virtual, and you all know why it is so. You know, what befell us by the COVID, it wasn't our making. But I really want to thank God that we are pulling through. I know it has hit hard on so many families, on so many countries, on so many individuals. It has really hit hard. But what I want to tell us is that there's light, you know, at the end of the tunnel. I mean, in a couple of weeks, it would have been 2 years that we had this mighty COVID, you know. But guess what? We're still alive. And then we really want to, you know, extend our condolences to families that have really lost their loved ones. And I really want to welcome all of us, and I'm sure you're going to really have a good time today with us. We have good panel of speakers from Professor Mishra, Dr. Nzeru, Dr. Castillo, Dr. Ransubak. We are very glad that you're with us. And then we have our students who are going to present. And then before I take my leave, I also want to use this opportunity to thank the Dean of the Faculty of Medical Sciences, the University of the West Indies, St. Augustine campus, Professor Terence Simongo, for his support, and then for backing us with this program. And then all our sponsors, Mark, Sharp, and Dome, the Princess Town Medical Limited, Life Care Families, and so many others to mention, but a few. So once again, welcome, and God bless. Thank you. Back to you, moderator.
Thank you very much, Professor Akpaka, for your warm welcome. Ladies and gentlemen, we have a very special and distinguished guest among us this morning, Professor Simangal. Professor Terence Simangal is Dean of the Faculty of Medical Sciences, the University of the West Indies, St. Augustine campus, Trinidad and Tobago.
Monica, we're not hearing you.
Prof, you able to hear me? All right, sorry about that. Well, so Professor Simangal has completed his MBBS degree at
Dr.
the...
Monica, we still cannot hear you.
It might be a problem with your connection.
Right, go ahead now, let's see.
Prof, can you hear me now? Dear all, can you hear me now? Hello?
Well, if we cannot hear you, maybe I'll take the honor to welcome our Dean.
Yes, please, Prof.
But everybody else is hearing me.
Yeah.
It's just not wrong.
And
Some of us can hear though.
Professor Simangal, are you able to hear us,
right,
please?
so let me take the privilege to welcome our Dean,
Yeah.
Professor Terence Simango. I mean, this is a man that doesn't need introduction. For those of us that are in academia, especially in the universities of the West Indies that has so many campuses. Well, he's the Dean of the Faculty of Medical Sciences at St. Augustine. And we're so glad that he has consented, you know, to bring some opening remarks and to declare this August meeting to declare it open. So without much ado, let me welcome Professor Terence Simongo. Prof, over to you, sir.
Okay, thank you, Patrick, and thank you, Chairman Dr. Unakal. It is my pleasure to be here today. I am very happy to acknowledge the president of the association, Professor Akpaka, who is also head of the Department of Paraclinical Sciences here at St. Augustine, and the many distinguished colleagues who have come to support this meeting. And I notice we have had, or there are, panelists from overseas, which gives a nice international flavor to this meeting. And I want to commend the association for doing so. But the science of medical microbiology is a fairly young science with very, very, very deep roots. Since the agricultural revolution, which is thought to be about 10,000 years ago or more, we have been plagued by infectious diseases. It's really a problem of settlement, because prior to this, you can think of tribal societies. We can't even use the word societies, but tribes. It's hard for you to get epidemics, isn't it? Think about it. Because people don't stay in one place for long, and there are not many of them together. And if an epidemic that's highly lethal breaks out in a tribe, they all die. But once people settle down, there is this risk. And there's no disease perhaps that demonstrates how quality of life affects risk of infectious disease. No disease that shows this better than tuberculosis. But let's go back a little further. The plague of Justinian is going back about 2,000 years. And that was an infectious disease. They didn't quite know the cause of it, but it came back, has hit us several times, but came back as the bubonic plague in the 1300s, which decimated the population of Europe by about 25%, and it took them 200 years to recover that population. But the real emphasis on infectious disease came in the late 1770s, when Edward Jenner made his discovery about smallpox. And then, of course, vaccination, when he found that the cowpox antigen could protect us from smallpox itself. And of course, we get into all the issues with vaccination, which are hitting us right now. But that's not the focus of my talk. It is at that stage, it seems to me, that microbiology and public health sort of came together. And public health initially focused on infectious diseases. But in the last century, public health mutated, if I could use that term, to look at the non-communicable diseases as well. But going back to the point I made about tuberculosis and the watershed between microbiology, medical microbiology, and public health, the incidence of tuberculosis in England started to fall from 1835, which is 100 years before the antibiotic era of the 1950s. And that had to do with improvements in lifestyles. And that is the key issue that faces us with the challenge of infectious disease today. How do you prevent spread? The scientific basis of that clinical practice is what we are looking at in microbiology, and therefore it is an extremely important part of the whole realm of medical sciences. And today we are faced with a disease that is hitting us that has a death rate of about 2.5% roughly, and that's been the death rate worldwide if you look at the number of cases. So I'll use the word the case fatality rate, because I suspect the true death rate is much less than that, because our case fatality rate will not include a number of the asymptomatic cases, which just wouldn't come to attention. I mean, we only see people who have symptoms. So it may be about 1%, but even so, if you consider that the death rate or the number of deaths per year in Trinidad is about 15,000 for a population of 1.5 million. So that puts us at about 10,000 in a population of 1 million. And you have a disease with a death rate of about 1,000, you realize you'll get a lot more added deaths per million. And that is the issue with COVID. And also that it takes with it people of all ages. More the elderly, yes, but we have had a lot of middle-aged deaths recently in Trinidad and Tobago. But it's not the first pandemic of this type. It's thought that in the 1890s, there was a coronavirus pandemic. Difficult to prove because, of course, we didn't have these sophisticated methods of diagnosis as we have today. And that is another area where medical microbiology has improved greatly and is taking the rest of medicine with it. And then in 1917, we had the flu pandemic. And it took about 15 years to determine that this was actually the influenza virus, because some people thought that it was in fact the plague coming back to haunt us. And we had a lot of difficulties, the whole interface again between medical microbiology and public health, where scientists were saying keep people isolated, and people didn't want to do that. And in Philadelphia, they opened up for some celebration. I think it was in 1918 or late 1917 when they thought everything had died down. And within 8 hours, the hospitals were full. The mortality rate from the influenza virus of 1917 was far greater than in the pandemic we see now. There have been a lot of triumphs, well, not a lot, but a few triumphs, in the sense that medical microbiology has helped us to eradicate smallpox and almost eradicated polio. Malaria is another challenge. A large number of deaths worldwide. It was at one time the #1 killer. I don't know if it still is, but you all will be better advised on that than I. And the issue there again is prevention. HIV is another pandemic that has hit us since the 1980s. But herpes and HIV and malaria doesn't tend to stir the imagination as much as COVID, because diseases that spread by the respiratory tract do so more easily and are more widespread in the population. I am hopeful that and this pandemic has helped us to advance medical diagnosis. And I'm hopeful that by having more rapid diagnostic techniques and that with evolutions that are going to occur in different types of drug therapy, that we will be able to bring this one under control soon. So in the midst of this challenge, you have convened your meeting, and I hope that you will have some interesting recommendations for us about prevention of the spread of infectious diseases. And also, I hope that you will have some important declarations to make that will help the Caribbean go forward as it manages infectious disease. I thank you once again for inviting me to speak, and I certainly wish you all a very successful meeting. Thank you.
Thank you very much, Professor, for your insightful opening remarks. We were very glad to have you with us, and thank you once again. Ladies and gentlemen, now this event, CACM Annual Symposium, is having 3 main components. Session 1 includes keynote addresses, and session 2 is about research presentations, and session 3 is on panel discussion. To begin with keynote address, may I request Dr. Glendy Reynolds to chair the session. Dr. Glendy is with us?
Yes, I am.
Thank you very much. Well, so Dr. Glendy Reynolds Campbell is a consultant microbiologist and lecturer at the University of West Indies, Mona Campus, Jamaica. Dr. Reynolds Campbell is also a National Infection Prevention and Control antimicrobial resistant consultant for PAHO, Pan American Health Organization, Jamaica office, and has an avid interest in diagnosis and treatment of fungal diseases. Dr. Reynolds is also the current ongoing president of the Caribbean Association of Clinical Microbiologists. Dr. Glendy Reynolds, thank you for being with us. Now the floor is over to you.
Thank you
Thank
for
you very
having
much.
me. Thank you. And I would like to say good morning, good afternoon, good evening, and good night to all of you wherever you are today. At this time,
Dr. Glendy,
yes,
my apologies. Can I have 2 minutes, please?
sure, not a problem.
All right. We have colleagues, one of our colleague, Dr. Arvind Kurade, who is in India. In fact, we are so happy that he has organized a hybrid mode of replica of this conference in India. And about around 100 more students are watching our presentation on live stream using YouTube and Facebook. I will just hand over 2 minutes the floor for Dr. Arvind Kurade, and then we will come back to you to start with the keynote presentations.
No problem.
Dr. Kurade ji.
Good morning, Dr. Arvind Kurade from India. And this CSM 17 is also, we are hosting in India, and around more than 100 participants are joining. Now I have Dr. Yadnesh Thakur, who is a international faculty. I have Meena Mishra, who is professor and head of All India Institute of Medical Sciences. I have Kalpana Date, who is a professor of microbiology. I have Sachin Devkar, who is a past president of Indian Association of Medical Microbiology. I have Dr. Geeta Kurade, who is also faculty of University of West Indies. And also we are having the professor and head and dean of Government Medical College with us today. And thank you, Dr. Unikal. Thank you, Dr. Prof. Akwaka. And we are having Professor Professor Dr. Ashok Pathak, who is professor and head and dean, Government Medical College, Nagpur. Dr. Suresh Akulwar, who is professor and head, microbiology, Government Medical College. Dr. Neena Nagdev, professor and head, Government the Lata Mangeshkar Medical College, Nagpur. Dr. Sharmila Raut, professor and head, Government Indira Gandhi Medical College, Nagpur. Dr. Sangeeta Bhallavi. Now Dinesh, Dr. Dinesh Agrawal, who is current president of our organization. And this is all we are having physically, we all are present from India. And thank you very much. And
Thank
this
you
is
very
how,
much.
yes, we have made the forum and stage, and everything is, we are physically doing the CACM Symposium from India. Thank you, Dr. Unikal. Yes,
thank you, Dr. Kurade, for wonderful arrangements. We are glad to have you all from India. Thank you for being with us. Now,
there are two presentations from India, and there is some connectivity. Sorry, I apologize for that. But we are physically there from India. Thank you, Dr.
Kurade. Thank you very much, Dr. Kurade. Now, I request Dr. Glendy to take over the floor. Thank you very much.
Sure, thank you, and welcome to everyone from India. It's a pleasure to have you with us today. Our first presenter this morning is actually from India. She was just introduced to you, just a quick introduction, but I'll tell you a little bit more. We have Professor Meena Mishra. She is a professor and head of the Department of Microbiology at the All India Institute of Medical Sciences in Nagpur, India. She's had more than 22 years of research and teaching experience. She's worked on as the Integrated Counseling and Testing Center for CDC Laboratory for HIV positive patients. She's been instrumental in getting the HIV diagnostic lab accredited. She has developed more than 50 national and international invited lectures and delivered them. She has conducted over 200 human resource development training programs. She has had several awards. She is the secretary of the Maharashtra chapter of Indian Association of Medical Microbiologists, and actually she's the president of the Vidarbha Association of Medical Microbiologists. Without further ado, she has many accolades, and we're very pleased to have her with us today. I introduce to you Professor Meena Mishra, and she'll be talking to us today on the topic of drug resistance. Who is responsible? Professor Mishra?
Thank you so much, Dr. Glandy, for those wonderful words. And before I start, I would like to on my screen sharing. So I think you should allow me for screen sharing.
Dr. Mishra ji, now you have credentials to share your screen.
Okay. Yeah. Okay. Is the screen visible?
Yes, we can see it.
Okay. Okay.
Fine.
So a very good evening and namaste from India, and good morning to all of you at Tobago, Trinidad. It is indeed a privilege for me to be the guest speaker in the 17th Annual Symposium on AMA and Emerging Pathogens in the Caribbean. At the outset, I would like to express my greetings to Professor Patrick, Professor Terence, the chairperson, Dr. Glandy, Dr. Arvind Kurade sir, Dr. Chandrasekhar Unakkal sir, ladies and gentlemen. The topic of my talk is drug resistance. Who is responsible? Now, whenever we talk about sharing the onus of, especially of some important or big problem, so fixing onus on somebody is a very challenging task, and nobody is ready to accept it. In this particular challenge, is it the microbe? Is it the microbiologist or the clinician? That is a question. When we have a look at this exhaustive list of the antibiotics which are available, the physicians at times, they are completely perplexed that which antibiotic should be given, and especially in the background of the antimicrobial resistant genes. And we have the microbe, and it has always been a race between man and microbes, and always it is a seesaw ride kind of thing. And microbes, they keep on waiting that you, buddy, you try antibiotics on me and I'll prove to be more smarter with my resistant genes. When we talk about antimicrobial resistance, when a microbiologist issues a report that it is a sensitive organism, it means that these sensitive organisms, they do not have the resistance conferring factor. Clinically, it means that sensitive organisms are those which are controlled. Okay. By clinically, you mean that their sensitive organisms are those which are controlled by therapeutically achievable levels of antimicrobial agent. Means when we give that particular antibiotic against that pathogen to the patient, he should respond to that particular dose, and vice versa is true for the resistant strain. Now, the problem is with the intermediate strains, whether they will respond to that particular antibiotic or not. Susceptibility is expressed in terms of the minimum inhibitory concentration. So let us have a look at the mechanisms of the bacterial resistance. How do they do it? Not all the antibiotics, they kill the bacteria in the same way. They have different mechanisms by which they act, and various classes of antibiotics work on different aspects of bacterial replication. Now, if we have a look at the mechanism of action, now the penicillin and the cephalosporin group, they act on the inhibition of the cell wall, whereas bacitracin and colistin, they cause leakage from the cell wall. Inhibition of protein synthesis, it is done by tetracyclines, chloramphenicol, erythromycin, and aminoglycosides, they cause misreading of the mRNA code and they affect the permeability. Fluoroquinolones, they inhibit the DNA gyrase, whereas sulfonamide trimethoprim, they interfere with the intermediary metabolism. Now, all of us are aware that there are antibiotic inactivating enzymes, and to name a few, beta lactamases, which are active against the beta lactams. Then we have aminoglycoside modifying enzymes, which act on the aminoglycosides. Then we have chloramphenicol acetyltransferases, cephalosporinases, metallocarbapenemases, which cause inactivation of the antibiotic and make it ineffective. Then another mechanism of resistance is the decreased permeability, and there is impaired uptake of the antibiotics. Now again, it could be natural. We all are aware that there are differences in the cell wall of the organisms, and in case of acquired resistance, the changes in the porins, which may interfere with the antibiotic support, and here also the enzymes like beta lactamases along with porins, they can result in the decreased permeability of the cell wall. Another mechanism could be modification of the target. Now, it will result in less avid binding of the antibiotic, and it is commonly seen in the beta-lactam resistance in gram-positive organisms like Streptococcus pneumoniae, Staphylococcus aureus, and an extreme example could be the ribosomal modification, which makes streptomycin-resistant organisms use the antibiotic as the growth factor. There could be a development of an alternate metabolic pathway, which will allow the bacteria to grow in presence of the antibiotic. This mechanism is seen in glycopeptides, aminoglycosides, macrolides, sulfa-trimethoprim resistance, amongst the others. Then, again, the enzymes along with the drug efflux mechanism, it could result in the mutations because of overexpressions in some cases. And here, this could result in the rapid efflux of the antibiotic from the cell, making it ineffective against the particular pathogen. Now, when we talk about the resistance, it could be natural resistance or it could be acquired resistance. Now, in natural resistance, it could be the Enterococcus, which are naturally resistant to the cephalosporins. In acquired, it could be again the mutation. Mutation could also be the single-step mutation or the multiple-step mutation. Now, single-step mutations, they are mostly associated conferring upon the higher drug resistance, whereas the multi-step, they could result in the low level of drug resistance in the organisms. Then, all of us are aware that the gene transfer, it could be either mediated through the chromosomes or it could be extra chromosomal resistance. Now, the three horizontal methods of transfer, that is transformation through the free DNA, transduction through the phages, and conjugation. These are the three methods. Now, in vertical transmission, they are basically the intrinsic mechanisms, and that includes point mutations and the gene amplifications. Now, most of the, we all are aware that Pseudomonas, again, it is known to have multi-drug resistant strains. And there could be point mutations, which can be detected by different systems like multiplex PCR. And through that, what we can do is we can shift our attention from the broad spectrum antibiotic to narrow spectrum by identifying that particular gene which is responsible for the drug resistance in these bacteria. Then in extrinsic mechanisms, it could be the jumping genes, that are the transposons, integrons, plasmids, and this transmission can occur between chromosome to chromosome, plasmid to plasmid, and chromosome to plasmid. Now, this is how the population dynamics plays an important role. Now, here we can see that normally a cell, it might have a very scanty population of the drug resistance present in it. And when the multiplication is taking place, now the resistant gene population could still be very scanty. This happens in the normal multiplication. But what will happen? When we expose them to the antibiotic, Now, this antibiotic, it will kill the normal cells, but the resistant strains, they will thrive. And not only that, what will happen? These resistant strains, they will multiply exponentially, and the final product, again, here we can see that the resistant strains, they will be dominant, whereas the sensitive strains, they will be rare. So this is what happens when we do not use the antibiotics judiciously. Now, there are some reservoirs, and these reservoirs, they have increased over the period of years, and they are responsible for spreading the resistant genes. Now, what are they? The extensive use of antimicrobials in the medicine, then in the veterinary practice and the agriculture. In veterinary practice, antimicrobials are used as growth promoters. They are also used as prophylactic drugs and also as therapeutic drugs. Then hospitals and especially ICUs, they are the breeding of the multi-drug resistant pathogens. So this is all these factors, they are interconnected, that the antibiotic use in the medical field, in veterinary and in agriculture, this will again contribute to the local resistance strains. Again, the change of antibiotic, it will result in the change of antibiotic susceptibilities in pathogens, and not to forget in commensals and also in the colonizers. Now, again, this could, we consume the dairy products, we consume the meat products, it could result in the transfer of the genes and especially also the NDMs and the ESBLs, they can be transmitted through this, and it can result in the community spread and evolution of the adopted resistant organisms, and this causes the fixation of the resistance. Now, what are the factors which promote the development of antibiotic pressure and the resistance in bacteria? Now, once we are exposed to these resistant genes, it causes alteration of the normal flora. Now, there are some factors which contribute to misuse of antibiotics. Then the biggest problem is failure to follow the infection control principles and settings that foster drug resistance. Inappropriate antibiotic use. So use of antibiotics where there is no clinical indication. For example, person might be suffering from viral infections and may not need the antibiotics, and most of the times it might be a self-limiting condition. Use of broad spectrum antibiotics when they are not indicated, and inappropriate choice of the empiric antibiotics. Then again, it could be an inappropriate dose, ineffective concentration of antibiotics at the site of infection. We all are aware that whenever it is a CNS infection, so we need to give the appropriate dose and through appropriate route for that antibiotic to be available there. Then ineffective concentration of the antibiotics at the site of infection, and of course the inappropriate duration. What we routinely follow is that whenever an antibiotic is prescribed for a particular period that is indicated, most of the times the patient starts feeling in a day or two, and after that they stop the antibiotic because they are feeling good now. And what will they do when some member in their family, when they acquire infection, they will be circulating the same antibiotic to the family members. Then practices contributing to the misuse of antibiotics. It could be inappropriate specimen collection, selection and collection. So microbiology is all about the proper sample collection at the proper time in the proper container and properly stored, properly transported. That will result into 100% proper result. It could be an inappropriate clinical test or failure to use stains or smears. Very simple techniques like gram stain, Zedin stain, they could give you a clue that what is this infection pointing towards. Is it a gram positive infection or a gram negative infection, or is it positive for a acid fast bacilli? So these simple techniques also, they could give a preliminary clue to the treating physicians. Then failure to use cultures and susceptibility test. Then there is rapid spread of resistant pathogens, and this is attributed to the increasing mobility of the society. Nowadays, the entire world has become a global village, and the connectivity between the different countries is very good. It could be demographic changes, it could be deteriorating hygiene, or it could be institutional opportunities like daycare centers, old age homes, hospices, etc. Now, what are the determinants of antibiotic prescribing? There is lack of appropriate knowledge, so that will result in the antibiotics being not judiciously prescribed. It could be a lack of trust or delayed result. It could be a desire to meet the patient's demands, that at times they could demand that I need to be treated with whatever high-end antibiotics are there, and I need to get well soon and go back to my work. It could be a failure, it could be a fear of clinical failure on the part of the physician, and they may think that if I don't give the antibiotic on proper time, it may result in the clinical failure. Again, economic influence, it plays a big role. There could be inadequate drug supply. Then it could be a peer norm culture, that if the other person is giving rampantly some antibiotic, some high-end antibiotic to all the patients, so then it becomes a practice for us. And if there is a feedback that they are responding very well, so we also start doing the same. It could be the marketing influence, or now litigation nowadays is a big concern for the medical fraternity, and they become concerned that whether if something goes wrong and in the process of litigation, I may be fined for not treating the patient on the right time, and it could be lack of regulations and enforcements. This is a very interesting fact. This has been shared by the ICMR, that if we have a look at the facts, 30% of the hospitalized patients at any given time, they receive antibiotics. Now, over 30% of antibiotics that are prescribed are inappropriate in the community. Up to 30% of surgical prophylaxis is inappropriate. 30% hospital pharmacy costs are due to antibiotics, and 10 to 30% of the pharmacy costs can be saved by antimicrobial stewardship programs. Now, what are the factors which are responsible for inappropriate use in community? Having a look at the patient-parent factors, it could be an anxiety about getting rid of the infection very fast. It could be misconception about what antimicrobials do. It could be fever requiring antibiotics. It could be a belief in the physician's healing power, or it could be economic concern. Now, what are the main managed care factors? That it could be a cost-saving pressure to substitute therapy for diagnostic tests. And I think this plays a very major important role, that many times clinicians, they are not ready to convince the patients to go for the diagnostic test, so that at least the proper information can be availed at the proper time and the patient can be properly treated. It could be reduced appointment time per patient, and there is less explanation time, that the doctors or the healthcare workers attached, they are not able to do the proper counseling of the patient, that why it is important for him to take this particular antibiotic and why it is important for him to continue with the entire course. It could be responsiveness to the patient's complaint about inadequate antibiotic response. So these are all the factors which contribute to the inappropriate use of antibiotics in the community. Now, the question to be answered by all of us, how did we end up here? End up here because the statistics are indeed very alarming. If we have a look at the latest statistics which are received, they say that almost 700,000 deaths have occurred because of the antimicrobial resistance. And the projected figures are that by 2050, 10 million people, they will be losing their life because there will be no antibiotic available to treat the multi-drug resistant strains, or for that matter, the TDR strains. So the first contributing factor, bacteria. There is rapid dynamics of gene transfer between bacteria and the global spread of the resistance. Then the clinicians and the patients for the indiscriminate use of the antibiotics. Then again, the clinicians, healthcare workers, administrators, and the public for poor sanitation and hygiene. The ICMR has launched this concept of WASH, that is water sanitation and hygiene program, and this itself could cover it could tackle a large problem of the AMR. Then it's the need of the hour that the research scientists and the institutes involved in the manufacturing of the drugs, that they should come forward and try to search for new molecules, because there is alarming decline in the antibiotic development. Now, we'll talk about ourselves, our roles and responsibilities as the microbiologists. Now, having a well-equipped laboratory, the state-of-art facilities, and nowadays there are so many equipments which are available. It could be a multiplex PCR, it could be BioFire, it could be multi-TOF, and so on. So these automated instruments, they help a lot, and especially in curtailing the time, and we could be of help to the clinicians and the patients with delivery of reports in few hours time. Accepting and processing any specimen that is received, microbiologists, they have a very important role to play, that they should always insist on the representative sample. Then the interpretative ability, again, it plays a very important role, that the interpretation of the test result, it should be very clear. Then the correct report, it needs to be sent. If the proper sample has been received, all the tests, they have been carried out, but if the proper report is not communicated to the clinician, it would result in the wrong treatment. And also, the microbiologist should be able to discriminate between the contaminants, colonizers, commensals, and the pathogens. Then at times, the patient is having infection, but we are unable to grow the organisms by the routine culture media that are available with us, because they may be fastidious pathogens. So we should have that option of growing the fastidious pathogens also in cases where they are indicated. Again, overdiagnosis, because overdiagnosis will result in the exaggerated treatment of the patient, and again, that is a very important factor contributing to AMR. It could be a poor quality control. Now, quality, it plays an important role in any laboratory setup. It may be right in the phase of pre-analytical, analytical, or post-analytical phase. Quality at each step is very important, and whenever there will be a breach in any step, it will result in the poor quality control. And the most important thing, saying yes to everything the clinician demands. The clinician might demand you the sensitivity for the higher end antibiotics, whereas the preliminary report is saying that it is a sensitive strain, sensitive to most of the commonly used antibiotics. So you should insist the clinician that he should stick to those primary line of antibiotic therapy. Now, does microbiologists do this? Do they induce a faith in the minds of the treating physicians? Do they participate in the surveillance of trains and the susceptibility of the microorganisms by species and sites of origin? There are so many local data that is available. It may be a regional data, it may be a national data. So we need to be aware about what are the trends going on in resistance. Then do they have an infection control program in place in the hospitals? The most important thing is having an antibiotic policy, and the most important thing is the antimicrobial stewardship program, which needs to be in place. And the restricted use of DISC in the antimicrobial susceptibility testing. Of course, there are guidelines, CLSI guidelines are there, the UCAS guidelines are there, and they need to be followed whenever we are doing the susceptibility testing. So let us have a look at what are the antimicrobial resistance key prevention strategies. The most important is the pathogen. So our primary target should be at the level of the pathogen, that we should try to have good infection control practices in place so that it should not be transmitted as a nosocomial infection. If at all the infection occurs, the next thing is that you should be able to give the proper antimicrobial report so that the proper antibiotic could be given to the patient. If there is antimicrobial resistance which develops in this particular pathogen, it will result into the antimicrobial resistant pathogen. And we have already seen that in the previous slide, that what will happen if there is a resistant pathogen, it will multiply exponentially, and this cycle will go on repeating endlessly. Now, what should we do? The first step is we should try to prevent the infection from occurring. That is the primary responsibility. And if infection occurs, we should go in for effective diagnosis and the proper treatment using the proper antibiotics. And we should optimize the use of the antibiotics so that the antimicrobial resistance strains, they are prevented, and this will prevent the transmission of the resistant genes. And what we expect is the susceptible pathogens which will be susceptible to the different antibiotics. So these are the 12 steps to prevent the antimicrobial resistance. So the key to preventing infection, the key is to prevent the infections. Vaccinate whenever vaccines are available for those particular pathogens. That is the best way you can protect yourself. Then get the catheters out, because indwelling catheters, they are an important source of infections. Then target the pathogen and access the experts, diagnose and treat it effectively. Then the next steps are about using the microbials judiciously. So practice the antimicrobial control. Know when to say no. Treat the infection, not the contamination. Treat the infection, not the colonization. Use the local data. If at all you want to go in for starting the empirical therapy, and stop treatment when cured. So to prevent transmission, 2 important factors: isolate the pathogen and break the chain. Why we need to worry about this particular problem? Because this is the timeline of the antibiotics, and we can see that there are no new molecules at present, and whatever molecules have been discovered already, the resistant genes have been developed against them. So this is again, these headlines in the newspapers are really very scary, that bugs resistant to antibiotics will kill more than the cancer. There has been increase in the per capita income, and that has resulted in increase in the antibiotic usages also during the past few years. So we must use the antibiotics judiciously. The WHO theme for 2021, that is spread awareness and stop resistance, and handle antimicrobials with care. Previously it was antibiotics, they have replaced it with antimicrobials, so that it is placed now in a broader domain, including antibiotics, antivirals, antifungals, and the antiparasites. So again, back to our original question: who is responsible? So friends, we all are responsible. May it be the hospital, the treating physicians, the microbiologists, the people who are providing ambulatory care services, the administrators, the nursing staff, then patients themselves, the microbes, the environmental factors, the therapists, the families, the visitors, everybody, the agriculture sector. So everybody is responsible for this burning problem of today's world, that is the antimicrobial resistant. So responsibility, it starts with me, it starts with you. And so I found this lovely slide about Trinidad and Tobago, and it was wonderful interacting with all of you. Thank you so much. And over to you, Chairperson, Madam.
Thank you again. You have really helped us in reviewing all the components of antimicrobial resistance. And I especially liked and appreciated that compact list that you gave us that reminded us of how, all the steps that we can take to actually improve and remove the actual problem that is antimicrobial resistance. And it was clear from your presentation that we're all responsible for this. At this time, I want to invite persons who have questions to put it in the question and answer section. That's that little icon marked Q&A at the bottom of your screen. And at the end of the session, we will take those questions. At this time, I want to introduce to you Dr. Yagnesh Thakkar, who is a consultant microbiologist at Care Hospital in Nagpur, where he specializes in microbiological and molecular diagnosis of infectious diseases. He received his MBBS from the Government Medical College in Nagpur, and he also received his MD in microbiology at that same institution. He also has an MA in public administration from Nagpur University and is the former professor at the People's Medical College and is associate professor at the Government Medical College in Nagpur. He's had several articles published. He's co-authored several manuals, including manuals for infection control and clinical microbiology and immunology. He's authored a book on microbiology for MBBS students. He's been the president of the Maharashtra chapter of the Indian Association of Medical Microbiologists and was the past president of the Vidarbha Association of Medical Microbiologists. Without further ado, I invite you, Dr. Thakkar, to present your topic to us today on infection control practices in the operating theater. Over to you. I believe you may be muted.
Yeah, can you hear me now?
Yes, we can hear you now.
Yeah. I would like to have screen sharing, please.
Yeah, yes. All. Dr. Thakkar, already you have credentials to share the screen. You want me to share your PowerPoint? I can do that for you.
Yes, if possible, please do.
Yes, I will do it. Thanks.
Screen sharing.
Just a minute, I'll do the screen sharing.
Okay.
Yeah. Yeah.
Yeah, now can you see my screen?
Yes, we can.
Yeah.
Thank you. Respected Chairperson, distinguished members of Caribbean Association of Clinical Microbiologists, distinguished delegates, my teachers and colleagues sitting around me in India, Dr. Arvind Kurade, Dr. Pathak, Dr. Akulwar, Dr. Raut Madam, Neena Madam, and so many of them. It's a great pleasure and honor for me that I have been invited to deliver a lecture here. And the topic which is given to me is not directly related to the antimicrobial resistance, but it definitely has a lot of relationship with the drug resistance, because I will be talking about the hospital-acquired infections, and that too in operation theaters. And as we all know, that hospital-acquired infections, they result from the resistant bugs. So my topic today is infection control practices in operation theaters. When I was told to speak upon that topic, I was wondering that in AMR seminar, how am I supposed to speak about the infection control practices? But Dr. Arvind Kurade told me that we are all microbiologists and we also should know and understand the hospital infection control, and a microbiologist has a big role to play in hospital infection controls. So today we will talk about infection control practices in operation theaters. It is a big topic, but we will talk only about the environment in the operation theater, and we will not, we'll just touch the other aspects of infection control in the operation theater. So whenever somebody suffers from the infection in the operation theater, he suffers from surgical site infection. And if we have to define the surgical site infection, it is the infection on the surgical site that occurs within 30 days of surgical procedure, or within 1 year if there is implant or foreign body. Now, these surgical site infections, we all know that they can be superficial, deep, or organ specific. Now, most surgical infections result from contamination of surgical wound with patient's own flora of the operating room personnel, and environment of the operating room. And the common organisms which cause the hospital-acquired infections are Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, Staphylococcus epidermidis, Escherichia coli, Klebsiella, Pseudomonas, Proteus, and other pathogens also, but these are the common ones. Now the question is why we talk about the surgical site infection, and why we are worried about surgical site infection, and why we want to prevent it. Now, if we see the statistics, the surgical site infections are the third most common hospital-acquired infections, which account for 14 to 16% of all hospital-acquired infections. Among the surgical patients, the SSIs were the most common and account for approximately 40% of the healthcare associated infections. And out of all the surgical site infections, 67% are incisional infections, that means they are confined to the incision, and 33% of the infections are organ or space infections. Now, these surgical site infections, they increase an average of 7 days to each hospitalization, along with a financial burden. And in a country like India, where there is a lot of private hospitals, then the burden on the patient is really very high. Apart from this, the complications of surgical procedures cause considerable morbidity. And when these occur deep at the site of the procedure, they can carry the mortality of as high as 77%. So the prevention of infection is a priority in operation theater, or we may say that in any healthcare areas. And the question is, how do we achieve that goal? The infection prevention in operation theater room is achieved through prudent use of aseptic techniques in order to prevent contamination of the open wounds. Isolate the operative site from the surrounding unsterile physical environment, and create and maintain a sterile field in which surgery can be performed safely. The possibility of surgical site infection depends on various elements. There is a possibility of surgical site infection which depends upon the susceptibility of the patients. It means if the patient is an aged patient or a very young child, or the patient is immunocompromised, or the patient is suffering from diabetes, or is having some other complications of autoimmune disease. In such cases, the patient is more susceptible to the infections. Then there are factors which are associated with the surgery itself. It means what type of surgery it is, whether it is a clean surgery, whether it is clean contaminated surgery, whether it is a contaminated surgery, or whether it is a dirty surgery. Plus, it also depends upon the complexity of the surgery. Duration of the surgery, longer the duration, more are the chances of acquiring surgical site infections. And of course, the proficiency of the surgeon who is doing the surgery. And then there are factors which are related to the environment of the operation theater. and we will be talking more about the factors which are related to the operation theatre environment. Now, many factors play a role in infections that are acquired in the operation theatre. So prevention of post-operative infection is dependent on several factors, and it begins with the effective theatre design. So right from the construction time, we have to take into account the prevention of infection in the operation theatres. Then, very important, sterilization and disinfection procedures, bacterial contamination of the theatre air, and the discipline of the staff, which includes restricting the movement of the staff within the operation theatre area. So more is the movement, more is the chances of getting the atmosphere contaminated, more are the chances of acquiring surgical site infection. So if we look at the planning, now the operation theatres will have different designs depending upon the size of the hospital and the availability of the space and so on. But we have to ensure that while we plan the operation theatre complex, it has to be divided into 4 zones: protective zone, clean zone, sterile zone, and a disposal zone. Protective zone means few people will enter that area. Clean means the atmosphere there is clean. Sterile means the atmosphere there and everything is completely sterile. And finally, whatever has to be disposed of, it has to be disposed of from a different, altogether from a different area and different route. This is just an example which I'm showing here, that this diagram shows some basic idea about the 4 zones in the operation theatre. We can see here that in the very first area, there is a corridor which is called as a protected corridor, and where the entry is somewhat restricted, but the attendants and the patients can enter in this area. Following that, the next is the clean corridor. So here, even fewer people will come, and then there is a sterile area, and operation theatre itself is in the sterile area, and at the end, there is an area for disposal, and there is a separate corridor for disposal. And you can see here that this sterilization unit is almost attached to the operation theatre, and it has got a very nice compartmentalization that here we have from the disposal area itself, we get the contaminated instruments for sterilization. Then they will segregate, they will wash, assembly, sterilize, and then store. And from altogether a different route, they will enter the operation theatre. So this is a sort of the diagrammatic representation which we should have in the operation theatre. Now, what are the advantages of this zoning? This zoning minimizes the risk of hospital infection. It minimizes the unproductive movement of the staff, supplies, and the patient. It increases the efficiency of the operative team members because all the movement is unidirectional from the protective area to the disposal area. So it also ensures the smooth workflow. It decreases the hazards in the operating room, and it ensures proper positioning of the equipments. Now, while establishing the operation theatre, we have to consider few things. The floors and walls should be absolutely smooth and easily cleanable, and should have minimum and neatly made or no joints at all. Flooring should be non-porous, scratch-proof, anti-skid, and anti-statics. The wall should be covered with smooth material like granite with minimum joints. The ceiling should be painted with oil paints which give smooth finish. All electrical fittings and water pipelines in the operation room must be concealed. The operation room complex should have only one entry, and all the windows should be airtight in restricted and semi-restricted areas. Now, when we talk about the environment of the operation theatre, air can be a risk factor in the operation theatre. So microbiological contamination of air in the operating room is generally considered to be a risk factor for surgical site infections in a clean surgeon. Microbiological quality of air may be considered as a mirror of hygienic conditions of the operation theaters. Now, this has a relevance when we talk about the surveillance in the operation theaters. Now, the factors which influence the airborne contamination in the operation theaters are the type of surgery, the quality of air that is provided in the operation room, the rate of air exchanges, the number of persons present in the operating theater, movement of personnel in the operating theater, level of compliance with infection control practices, quality of staff clothing, and quality of the cleaning processes. Any deviation in the standard operative procedures will lead to excessive contamination of the air and will increase chances of the surgical site infections. And therefore, maintaining the operation theaters is a priority, and stress must be laid on the temperature of the operation theater, humidity in the operation theater, ventilation, and pressure. They all should be such that then should not only provide the comfort to the patient and the staff who is working in the operation theater, but should minimize the multiplication of microorganisms in the atmosphere of the operation theater. So these are some standard parameters which have to be followed. Now we classify our operation theaters in two categories. One is a general operation theater where almost all types of general surgeries are done. And then there are specialty operation theater where we do the transplantations, then cardiac surgeries, and neurosurgeries like that, where we have to be doubly careful that the patient should not suffer from any infection, because if such patients suffer from infections, it's likely to be very, very serious. So when we talk about these two types of operation theaters, we need to have at least 20 to 25 air changes with 4 fresh air changes. That is 30%, approximately 30% of the air changes in the general operation theater. In specialty operation theater, we should have more air changes with 5 fresh air changes. Now, airflow has always to be unidirectional. Air velocity is same in both the operation theaters. It is 90 to 120 FPM. Positive pressure, both the operation theaters, they should be in the positive pressure. The pressure of about 15 pascals is adequate. We must have the air handling units in both the types of operation theaters. You may have a smaller HEPA filter in general OT, but you will need a larger HEPA filter in the specialty operation theater. The temperature range should be 21 to 24 degrees centigrade. Ideally is 21 degrees centigrade plus minus 1 degree centigrade. And humidity should range from 40 to 60%. Ideal is 55%. At these parameters, the multiplication of organisms is minimal. Now, as far as ventilation is concerned, each operation theater room must have a dedicated air handling unit. And operation theater room ideally should have a laminar airflow with HEPA filters and pre-filters. That is very important. The laminar airflows can be situated in the center, or they can be situated in a horizontal manner also. But what is preferable is that they should be placed in the center at the top of in the center of the operation room, and where the patient's table is there. And the air will flow from top, and it will be removed from the exhaust which are fitted at the lower level, so that the air comes from the uninfected site to the possibly infected areas, and it is a unidirectional air. So these things are very important. Remember, in many operation theaters, especially in India, we have some operation theaters where there are window air conditioners, and we don't recommend the window air conditioners in the operation theater. They should never be used. Now, there are few basic things which we should adopt while taking care of the operation theater. Our aim is the reduction of microbial counts, and that is very important. It is also important to know that paying great attention to floors and using too many chemicals is not necessary. We have to keep floor clean and dry with vacuum cleaner and wet cleaning techniques. Keep the mops dry when not in use. Frequent cleaning of the walls and roof is not needed. Number of persons present and movements they make has a direct relation to increase the bacterial count. Now this point is coming again and again and again. So we should minimize the number of the personnel in the operation room, and their movement also should be restricted to the bare minimum necessary movement. And prompt disposal of theater waste out of the theater should be our top priority. It should not, the waste should not be accumulated in the operation theater. Now, as far as cleaning of the floor is concerned, a simple detergent reduces the flora by 80%. If you add the disinfectant, it reduces to 95%. So adding the disinfectant to while washing the floor will help. In busy hospitals, count of bacteria raises in within 2 hours. So in busy hospitals, we need more frequent cleaning as compared to the routine ones. The floor should be cleaned with vacuum cleaner. Use the wet cleaning techniques. We have to use the wet mop, and when not in use, keep the mops dry. I'm repeating again and again because these are the small things which are known to us, but which can be usually neglected by the housekeeping staff. Now, as far as the walls are concerned, frequent cleaning has a little effect. The organisms which are settled on the wall, they will not fly in the air and will enter the incision wound of the patient. So as far as possible, we should not disturb these areas unnecessarily. And whenever we wash the walls, wash with soap and water and then with disinfectant once in a while. In our country, we do it once in 15 days, or in some hospitals, they do it even only once in a month. Similarly, for roof, again, it should not be disturbed unnecessarily. Ceiling fan should not be used because these fans will cause aerosol spread. And the roof is cleaned only when there is a remodeling or we can see a good amount of accumulated dust on the roof. Now, we clean the operation theaters every day in the morning before we start our operations. Now, what we should do between the procedures in the operation theaters? We should clean between the two patients, we should clean the operation tables, theater equipment with disinfectant solution with detergent. In case of spillage of blood or body fluids, decontaminate it with the bleaching powder or chlorine solution or any other effective disinfectant. Always discard the waste in the prescribed plastic bags. Do not accumulate biohazard waste in the operation theaters. And do not discard the discarded soiled gowns within the operation theater room. At the end of the day, when you have finished all the operations, we have to clean all the tabletops, sinks, door handles with detergent, and low level of disinfectant can be used. Clean the floors with detergents mixed with warm water. And finally, mop with disinfectant at a suitable concentration. This suitable concentration is again very important. Low concentration of disinfectants serve only as perfumes and not as the disinfectants. Then one of the most important units attached to the operation theater or in any hospital, that is the Central Sterile Service Department, that is CSSD, or Theater Sterile Service Unit, that is TSSU. Now CSSD is usually seen in the bigger hospitals, and TSSU, which is restricted to the operation theater, is seen in the smaller hospitals. Now both these units should be as close as possible to the operation theater casualty laboratory ward, because there we will be needing a lot of sterile instruments and equipments. And its ideal size is 6 to 10 square feet per bed. So the size of the CSSD or your TSSU, it will depend upon the number of beds you have in the hospital. So more the number of beds, bigger will be your CSSD. Now we can have a separate discussion on CSSDs and TSSUs, But here we have to understand that they are very important departments. And as I have told you, I have discussed it in the earlier part, that it should have the separate areas of receiving, washing, then assembly and sterilization and storage. So all these things, they have to be followed, and there should be the separate SOPs and separate surveillance markers for CSSDs and TSSUs. That we will talk about that sometime later. Then environmental disinfection. Now, fumigation is an age-old process of sterilization of the environment, maybe a sick room or the operation theater. And it used to be usually done with the formalin, from which the fumes, they will emerge, which are very pungent and harmful. So when the room is fumigated, it is tightly closed and sealed before fumigation. The room is then opened after fumigation, after about 12 to 24 hours, and the room can only be used once all the fumes are out. So it is a very difficult, it is very effective in removing the microorganisms, but very difficult practically. And nowadays, it is not at all recommended to do the fumigation, especially using the formalin. So now people have resorted to the fogging by hydrogen peroxide. Now the difference between the fumigation and fogging is that fumigation is done by spraying the formaldehyde or the formalin in the air, and it will vaporize into formaldehyde and will kill the microorganisms in the air. Whereas in fogging, we use the fogger, by which the hydrogen peroxide along with the silver nitrate is sprayed in the air as a fine mist, the size of which is less than 50 micron. So they remain suspended in the air for a longer duration. And by remaining in the air for a longer duration, by oxidative killing, they can kill the microorganisms in the air. And it has got a distinct advantage that it is not at all corrosive, not irritant, non-carcinogenic, and you can open the operation theater within 1 to 2 hours. So it is very fast also. However, nowadays it is recommended that if you have got the air handling units with HEPA filters, the specific air handling unit that we call it as a laminar flow, then there is not even a need for fumigation or fogging. Only proper cleaning with disinfectant is good enough. And for that, we here use chemically bound formaldehyde combined with lutheraldehyde, benzalkonium chloride, and alkyl urea derivative. This is a very good disinfectant we have, and these we have been using for the deep cleaning wherever the laminar flows are present. Now here, a word of caution that many times what happens that we keep on cleaning the operation theater, we take good care of environment, but we forget certain places. And these are the tubings in the anesthesia machine and all that, and they may get contaminated and we may miss them, and this could be the source of infection. Very recently, I was called for the surveillance of an outbreak of infections in the operation theater, and I could find that these things were, you can see in the photograph that there's a lot of colonization which can be even visible to the naked eye. So cleaning practices of the environment and equipment are equally important, and our disinfection policies must be strictly followed. And we must never forget biofilms and microbial load. They are responsible for these infections. They can accumulate at any place, and we have to take care of these biofilms and microbial load. And of course, the microbial type, the virulence of the microorganism and their survival ability in the environment in case of saprophytes and the opportunistic pathogens is well known to all the microbiologists, and their potential to cause the infection is also known to all of us. Again, everybody in the hospital knows the importance of hand hygiene. So good hand washing practice will save many lives. And scrubbing before the surgery and use of the alcohol with chlorhexidine, alcohol without chlorhexidine, or plain chlorhexidine, they have got uses at different places at different times in the hospital. And you can use anything new that is also available, which has got a very good action on the microorganisms. Now, these are the commonly used disinfectants, and as we have already discussed, that they have to be used in the proper concentration, because if the concentration, they will kill the microorganism very effectively at a certain concentration. If the concentration is less, they won't be able to kill the microorganism. If the concentration is more, there will be better killing, but again there will be a problem of cost, because that will increase the cost, and secondly would induce some side effects. So commonly used are glutaraldehyde, we use at the concentration of 2%, phenol at 5%, sodium hypochlorite widely used and a wide range 0.5 to 5% at different places, chlorhexidine 0.1 to 2%, povidone iodine 10%, alcohol 70% to 90%. The concentration will vary with the clinical situation, and remember that while we use the commercial preparation, we have to use the dilution mentioned by the manufacturer, because every manufacturer will dispense that disinfectant at a certain concentration and will recommend a certain dilution, so that these concentrations which we need to achieve, they will be achieved by diluting that. So that is a very important, and that instruction we have to give to our housekeeping staff and our nursing staff, who will supervise the housekeeping staff in doing all this course. Now, apart from this environment, the surgeons, the operative staff has to adopt strict aseptic practices in the operating room. Proper preparation of a patient for clinical procedures is very important. Again, we will not go into the details of the proper preparation of the patient. Then hand washing and surgical hand scrub. 2 to 5 minutes surgical hand scrub is good enough. Using barriers, use of surgical attire, gloves, and proper donning and doffing of that attire. Maintaining a sterile field during the surgery. Using a good surgical technique is equally important, and maintaining a safe environment in the surgical and the procedure areas. These are the key factors which will further reduce the incidence of surgical site infections. Now comes the surveillance, and we are directly related with the surveillance. Surveillance means environmental monitoring. Microbial testing of air, surfaces, and equipment in order to detect changing trends of microbial counts and microbial flora amounts to environmental monitoring. Unfortunately, there are no universally agreed standards for any country or place regarding when to undertake microbiological sampling in the operating theater and on the interpretation of the sampling results. So every hospital has to formulate its own policy of doing the surveillance. Of course, there are certain guidelines that we should avoid routine sampling of the floors, walls, or furniture which are not in direct contact with the patients, and they are not the source of the infection. The organisms are mostly present in the air in the operation theater. If all the proper precautions are taken, the infection is usually acquired from the organisms which are present in the air. So air surveillance will become very, very important as far as the operation theaters are concerned. Now, for a microbiologist, there are 3 methods of air surveillance. One is the settle plate method, in which we keep the culture plate in the center of the operation theater and allow the organisms to settle on it passively when they settle down on the operation table. Then there is a slit sampler method, which is a fairly rapid method, more sensitive method, because it sucks a large volume of air in a short time. So this method definitely is a better method as compared to the settle plate method. And third is a particle counter, which we call it as a non-viable count. It is presumed that one particle will have one microorganism on it, and if the particles are counted, the number of particles are directly proportional to the number of organisms in the air. That is the contention, and on the basis of this, we can do the air surveillance. Then in many operation theaters, the swabs are taken from the walls, from the floor, from the operation table, lights, and some instruments, trolleys, and anesthetic equipments, and they take before fumigation and after fumigation. Now, if they are taken before fumigation, they are not at all required because they will tell you only about the resident flora of that hospital. After fumigation, if they are taken, it only confirms the quality of your fumigation procedure, because fumigation should kill all these microorganisms, and after fumigation, if you do it, you should not get anything. So that is only for the quality control of your fumigation processes. So what routinely should be done is the air sampling in the hospitals, in the operation theaters. Now, the other swabs, the examination by the swabs has to be done only when indicated, like whenever there is an outbreak in a certain area, then only swabs and extensive search for the source of pathogen can be done. Now, as far as operation theaters are concerned, there are some bacterial limits which are recommended. So again, we divide operation theaters into two: clean operation theaters and the general operation theater. So for the clean operation theaters, the bacterial limits are less than 1 per cubic foot. So if we convert it into meters, so it should be less than 34 per meter cube. And if we are using the settle plate, then they should be less than 10 per meter square per minute. For general operation theaters, the limits are more. So the bacterial count should be less than 10 per cubic foot, less than 353 per meter cube, or for settle plates, less than 106 per meter square per minute. We have to remember that the air sample should not have a single colony of Staphylococcus aureus or the gram-negative bacilli. If they are there, then your operation theater is not suitable to perform the surgeries. In our country, we used to test for Clostridium species. Routine testing for Clostridium spores is not mandatory except during certain situations like new constructions or structural alterations in the operation theater. Whenever there is civil work is done and we expect a lot of dust and dirt and dirty material, then only once you have to look for Clostridium species when we are starting your operation theater after these manipulations. Otherwise, there is no need to test for Clostridia. And whether it is the operation theater or whether any place in the hospital, no disinfectant is a substitute for hand washing. The use of personal protective equipment whenever indicated, appropriate handling of patient care equipment and soiled linen, the prevention of needle stick and sharp injuries, environmental cleaning, appropriate handling of the waste, and taking care of yourself. And we have to remember one thing as the microbiologist, that we place many standard operative procedures in our operation theaters. We teach our staff, we educate our staff, and we try to follow all the precautions. But many times there is a breach. And to find out that breach and to keep on monitoring that whether everything is going on well and according to the standard operative procedures, surveillance is very, very important. So we must have proper policies for doing the regular surveillance in the operation theaters. And there is a very important job of microbiologists, because microbiologists has to keep a watch on all these things, because whenever something goes wrong, it will be the microbiologist who will have to find out what has gone wrong and where has gone wrong and what measures that one has to take to rectify that error. So thank you very much for your patient listening.
Thank you, Dr. Thakkar. That was a very interesting and very concise presentation on how we can help to prevent infections and their spread in the operating theater. At this time, I want to introduce to you your next speaker, who is Dr. Chike Nazeru. He is a professor of internal medicine at Meharry Medical College in Nashville, Tennessee. He's a professor of healthcare strategy at the Roseman School of Medicine in Henderson, Nevada, and he holds an MBA from Oxford University. Dr. Neziru has more than 30 peer-reviewed publications in journals that are centered in the world of nephrology. And as such, today he'll be presenting to us on the topic, screen jumping, presenting to us on the topic, molecular virology of kidney involvement in COVID-19 infections. Dr. Neziru, over to you.
Dear Chair, just a moment. I'm going to share the slide. Dr. Nazare.
Yes, thank you very much. Good morning.
Just a moment.
Good afternoon.
Oh, you're going to do it, or you want me to do that for you?
No, you can move the slides and then I'll just talk on the slides.
Thank you.
So while you're setting that up, I just want to thank the leadership of the CACM, Professor Paka, who was my classmate from medical school, and Dr. Chandra Sekar, who we've been exchanging emails and communication about this presentation. This is actually my second presentation to a clinical Caribbean society. In 2002, which seems like eons ago, I did do a presentation for the Caribbean Society of Clinical Pathology. And that meeting was held at St. Kitts and Nevis. So I did a presentation on kidney involvement in tuberculosis in patients with HIV. So it's today my presentation is basically a kidney-centric view from a clinician standpoint. Some of what we've learned with COVID-19, how it affects the kidney, how does it get to the kidney, why there appears to be so much kidney involvement, and then how it affects kidney patients, and then the subject of vaccination for kidney patients and why that's very challenging with COVID vaccines. So if I could get the next slide. So the goals of my talk will be to highlight the kidney disease that we have seen with COVID-19 and try to discuss the pathogenesis of those effects on the kidney, review why should we really care about how the kidney gets involved with COVID, and why it appears that when the kidney is involved, the outcome is not so good. Is this an epiphenomenon, or are there other ways that getting the kidney involved in this disease appears to reduce the chances of survival? And then we talk about some of the antiviral therapies and the issues of vaccination for patients with kidney disease against COVID. Next slide. So this is talking to a microbiology audience. You guys are the experts on this, but I thought I'll start by looking at sharing the structure of the SARS-CoV-2, which is the virus that causes COVID-19, because I would piggyback on this on some of the aspects of therapy or discussing some of the pathogenesis. So it is an RNA virus. So you have the genomic RNA in the middle, and then you have critical proteins such as the spike protein, which is helpful for attachment, which is the first stage that helps the virus get in or get onto cells. And then you have the membrane proteins and the envelope proteins. And some of these structures or proteins are also pertinent when we talk about the different vaccines. Next slide. So this slide actually tries to summarize some of the other coronaviruses that have caused major human diseases. And it appears the primary host appears to be bats for a lot of the coronaviruses. So in the early 21st century, we had MERS-CoV infection, which was ravaged through most of the Middle East. And then we had the SARS-CoV-1, which affected, mostly China, the Southeast, and we had some cases in Canada. It wasn't as widespread as COVID-19. And then the human involvement in this, we are kind of like the tertiary hosts. The other point to remember about this is that the other two, so SARS-CoV-1, which happened in 2003, and MERS-CoV from 2012, neither of those had major kidney involvement. Those patients, there was also significant mortality, morbidity, but somewhat less than the 2.5% that we appear to settle for the mortality of SARS-CoV-2, taking into consideration some of what the dean said about the fact that, the case fatality rate may actually be an overestimate because minor cases don't get counted. But so these other two coronaviruses, we didn't have kidney issues. In fact, I never heard about or read in a journal about kidney involvement with those two. But with SARS-CoV, it's been a major issue. And next slide, we'll talk about some of the reasons why. So basically, this is a clinical look at some of the organs that have been involved with SARS-CoV-19. Basically, a lung infection. It starts out as a lung infection. You get acute lung injury, acute respiratory distress syndrome. So acute respiratory distress syndrome is not a new disease. We know that this can happen anytime you have sustained injury in the kidney. It's a kind of a non-cardiogenic interstitial edema. And from the lung, there appears to be clear evidence that pro-inflammatory mediators lead to a cytokine storm. There are issues with coagulopathy and microangiopathy. And then we have myocarditis, as a complication of the infection. And sometimes we also see myocarditis after vaccination for COVID. And then the acute kidney injury. And we'll talk about some of the potential mechanisms that drags the kidney into this maelstrom of bad or serious cases of SARS-CoV-19. Next slide. So this is a brief schematic of the genome of SARS-CoV-1 and MERS-CoV and then SARS-CoV-2, just showing some of what they share in common and then the differences in their genetics. Next slide. So how does it get into the lung cells? We already talked about attachment being the first stage of viral infections, very common pattern for a lot of RNA viruses. So it appears the spike protein appears to play a key role. So the spike protein subsequently was shown to help attach to the lung cells or the type 2 pneumocytes with the help of angiotensin receptor 2. And after that, you get endocytosis, membrane fusion. And then once it gets in, you get replication of the virus and then more viral release and then impacts the lung cells and the alveoli. Next slide, please. So it is a respiratory illness. So basically presents as pneumonia. We talked about the ARDS. And one of the few things the first things we noticed with this virus was the idea that once there's significant injury, the chest X-ray findings are pretty dramatic. And then after the chest X-ray, we also realized that when you take a CAT scan, it just looks like you have, ground glass appearance on the CAT scan. And that basically shows significant lung injury, which sets the stage for the rest of what COVID-19 will do to the patient. So it starts out respiratory and then subsequently spreads from there. Next slide. So what became very evident early in the course of the pandemic is that in Nevada, we were seeing a lot of kidney patients, kidney involvement. People were getting on dialysis who had normal kidneys a week or two before. We noticed that those who were in the ICU with COVID, their rates of kidney disease was higher, and different studies were being published, but the range of kidney involvement varied between 10 to 35% in hospitalized cases. Once again, this is an overestimate because a lot of patients who were managed at home who recovered didn't have any kidney involvement, or if they had kidney involvement, they recovered. So that data is still questionable. I would share one prospective study recently, actually in the October issue of a kidney journal that did a much better job because they looked at everybody who had COVID pretty much and trying to determine what the percentages are. So when the kidney gets involved, so there are two functional units in the kidney. So each kidney has about 1 million nephrons. The nephrons are made up of tufts of glomerular capillaries, and then the tubules that do the function of filtering plasma. So both sides, the glomeruli and the tubules, can either separately be involved or both of them can be involved. Next slide. So this slide just reviews some of the mechanisms that have been reported to explain why or how the virus involves the kidney. Some have argued that whenever you have sepsis or septic shock, so septic shock is a clinical syndrome where you have a severe infection that eventually has bacteremia, septicemia, and in case of gram-negative bacteria, you have lipopolysaccharides and chemical components being released that lead to vasoactive issues, hypotension. And then once you have hypotension, the kidney gets 25% of the cardiac output. So whatever mechanism in the body leads to hypotension and reduced blood supply to the kidney away from that 25% that it normally gets of the cardiac output, then the kidneys start suffering. Then you have reduction of blood flow, the GFR goes down, so that leads to what's called pre-renal kidney failure or acute kidney injury. There are also reports of cellular toxicities, and I think I have some kidney biopsies where you would see clearly that there's cellular damage to the kidney directly as a result of COVID-19 infection. So there is direct cytotoxicity as a mechanism of kidney damage in COVID-19 infection. Coagulopathy is another major phenomenon that has been reported not just in the kidney, in many vascular beds. It's thought that COVID-19, part of the pathogenesis, there's alteration in the coagulation system. In the interest of time, we're not able to go into the mechanism that underlie that. But let me just give you an observation that some of us have made. I have seen more DVTs and PE in the 22 months or so of COVID than I saw in the preceding 10 years. And I'm a nephrologist. I don't usually see them. These DVTs go to the internal medicine team or the pulmonary doctors. But as a nephrologist, I have seen more DVTs and pulmonary emboli in the 22 months of COVID than I saw in the preceding 10 years. So there is no question there are issues with coagulopathy and part of the hospital management. Now we put everyone on anticoagulants, such as Eliquis, heparin, and that has actually helped improve the survival of patients. There's also the microangiopathy, so capillary dysfunction, capillary thrombosis. And we also saw in the glomeruli, we saw a situation where we're getting patients with collapsing glomerulopathy. So collapsing glomerulopathy is a common kidney disease that we used to see a lot in patients with HIV. So HIV, again, you have a viral disease where the glomeruli, the podocytes, the epithelial cells, the outermost layer gets damaged. Those podocyte damage, there's healing, there's scarring, and the glomeruli just collapse. we see this pattern of injury as well in COVID-19. So we now know that it's not specific for HIV, because here you have another viral disease that can do the same thing. But when the glomeruli collapse, then you have massive proteinuria, kidney failure, and we see a lot of this with COVID-19. Next slide. So in terms of with the kidney, or the treatment approaches in general, we tend to provide oxygen, support the blood pressure to help the kidneys, the antiviral drugs that we use, such as remdesivir, monoclonal antibodies, optimize blood volume to improve kidney survival. And there's a lot of people going on dialysis because of COVID-19. And then when the lungs are both seriously damaged, the kidneys are really bad, and they also have heart failure, we put them on a heart-lung machine, and this is called extracorporeal membrane oxygenation, or ECMO. And ECMO has seen a resurgence due to COVID, and in many cases, it's actually helped improve survival. If you remember, the British Prime Minister, Mr. Johnson, when he had COVID, for a while he had to go on ECMO, so it appears to help. Next slide, please. So this is just a schematic summary of, we said that when the COVID gets to the kidney, that the damage results from effects on the glomeruli, as well as the effects on the tubule. And so you have some this slide captures parts of the tubules that appear to be particularly impacted by COVID. So you have the afferent arteriole coming in on the left side, and then the efferent arteriole leaving out of the glomeruli. Some of the changes that we see, we have talked about the collapsing glomerulopathy, where the podocytes are damaged, and then the parietal layer of the Bowman's capsule is also damaged, and the glomeruli just collapses on itself. We have also seen thrombosis, formation of clots. We talked about DVTs and pulmonary embolism. So microthrombosis in the kidney is also a mechanism of injury. And then the proximal tubule is the first part of the tubule. And what's dramatic about the proximal tubule is that 2/3 of the energy used by the kidney is used by the proximal tubule. There's so much reabsorption. You have a glucose sodium transporter. So much that happens in the proximal tubule affects the final composition of urine. So this area of the proximal tubule is particularly also affected, since we are saying that 2/3 of the energy utilization, you have a lot of mitochondria in that area, you have a lot of organelles where oxygen deprivation, cellular toxicity would have major dramatic effects, leading to kidney damage. Next slide, please. So we talked about how the entry into the cells, but this slide only tries to highlight the role of the ACE2 receptors. So to your left, you have the normal scenario where the ACE2, the SARS-CoV-19 binds to the ACE2 receptor and then gets into the kidney and starts replication. But normally, the ACE2 receptor also has a regulatory role in keeping the capillaries open. They cause vasodilatation normally. They help healing, almost like a housekeeping function. And they have interactions between their function as well as ADAM17 and all, which connects to the coagulation system. If you have a scenario where SARS-CoV-19 binds to that receptor, there's high affinity for binding. And then you have a scenario where you now get, instead of the vasodilation, you're getting vasoconstriction, you're having thrombosis and inflammation, you have oxidative stress and cellular damage, leading to edema and high permeability in that area. And that's what leads to the major impact in the kidneys. The kidneys are rich in ACE2. Remember we talked about MERS, CoV, and then SARS-CoV-1, and we said these earlier two viruses from 2003 and 2012, there was almost zero kidney involvement. And what's unique about COVID-19 is this scenario where you're having almost 24 to 30% kidney involvement. And the ACE2 receptor has been proposed by people to be the reason why COVID-19 has so much tropism for the kidney cells, leading to acute kidney injury and a requirement for dialysis compared to the other two viruses. Next slide. So apart from the direct effects, we talked about direct cellular toxicity. We talked about the effects of septic shock, sepsis, cytokine storms. We also have other effects, indirect, that also could lead to kidney damage. We talked about the issue of endothelial dysfunction, the tendency to disorganize the communication between the kidneys, the glomeruli and the tubule. There's always backtalk between the glomeruli and the tubule. That's called tubuloglomerular feedback. Tubuloglomerular feedback is a way to tell the distant parts of the kidney to adjust their function to what the body needs based on information they are getting from the proximal parts due to the glomerulus. If you lose tubuloglomerular feedback, it leads to a high propensity for kidney failure. And this is also lost in COVID-19 infections in the kidney. Next slide. This slide tries to summarize pretty much all of what we've said about the reasons for how the kidney gets damaged acutely in COVID-19. We talked about the factors that happen before the kidney, so pre-renal, so loss of volume either due to shock, hypotension, direct tubular injury. We showed you evidence that these cells directly attack the podocytes, the cells that form the outer layer of the glomerular basement. There's also inflammation, so acute interstitial nephritis. Some patients, if you look at their urine, you see a lot of eosinophils or neutrophils, and I will show you some slides that highlight that. There may also be effects after the kidney. And some of those patients, if they put a Foley catheter, those do get better. There's also evidence for breakdown of muscle, rhabdomyolysis, in the setting of COVID-19. If you have ischemia of muscle groups, those muscles get destroyed, and then myoglobin pigments are rushed to the kidney in large amounts. They lead to acute kidney failure. We also talked about coagulopathy, an impairment of flow through the abdomen, sometimes called abdominal compartment syndrome, can also lead to acute kidney injury in the COVID-19 infection setting. Next slide, please. So this is just a schematic showing the ACE2 receptors in the kidney. These are kidney biopsy studies showing the high density. You have large amounts of ACE2 receptors in the kidney because the kidney plays a normal role in the renin-angiotensin system and the regulatory effects it has on the vasculature in both the kidney as well as the body in general. This is part of the way the kidneys help to maintain normal blood pressure. It just so happens that these same receptors are what the COVID-19 uses to gain entry into the cells and cause some of the damage that we have talked about. Next slide, please. So I think we already talked about this, that there's a housekeeping function for ACE2 in the kidney, that normally, you have angiotensinogen being converted to angiotensin 1 by an enzyme called renin in the lungs and also present in the kidney. Then angiotensin 1, which has 10 amino acids, is broken down to angiotensin 2, which has 8 amino acids by 8s. And then normally, what this does in the body, on the right side with the green, is that angiotensin 1, angiotensin 2, and to some extent angiotensin 1 to 7 causes vasodilation, they suppress inflammation, they inhibit fibrosis. And then on the left, when you have this receptor taken over by COVID-19, then you have activation of the renin-angiotensin system, you have vasoconstriction, inflammation, and fibrosis. And this is part of the mechanism that leads to the kidney damage that you see a high propensity of in patients with COVID-19 infection. Next slide, please. So I think we already covered that. And basically we said that, things can happen to the glomeruli and the tubules and lead to kidney damage in this infection. That ACE2 genes are critical for the viral kidney tropism that we see with COVID-19. There are effects due to inflammation, sepsis, hypertension. So we'll just go to the next slide. I think we already covered this. Again, this summarizes how the virus, we talked about how the virus gains entry in the lungs, how it actually gains entry into the kidneys is pretty similar. It's the same ACE2 gene that we talked about. In the middle, you have the glomerulus, which is the blood vessels that supply the kidney. We said the kidney needs a lot of blood, 25% of the cardiac output to do its job. And then it shows what happens when you have COVID-19 causing damage in the proximal tubule, in the glomeruli, and then activation of the renin-angiotensin system is just basically like pouring gasoline on a fire, and this cascade persists. And then there are other issues that lead to problems, like we talked about lung and heart dysfunction. And then when these patients get on the ventilator, we use a high level of pressure to try to force oxygenation of the lungs. And sometimes that can cause damage. Some of the medications like remdesivir that we use to treat these patients, they're also, if you remember, remdesivir was developed for Ebola, and it didn't do well against Ebola. But during the COVID-19 pandemic, there were two studies that showed that you can actually reduce the number of days the patients spend in the hospital, as well as improve some survival. Some of these studies were controversial because if you remember, the World Health Organization came out with an expert opinion saying, don't use remdesivir. But worldwide, we continue to use it because the idea that you can shorten the duration of hospital stay, there is value in that, even though you don't have a hardcore improvement in mortality, at least based on the trials that we have seen. Next slide. So this is a kidney biopsy showing what, I put this in because I remember one of the basic concepts that I liked so much as a medical student in microbiology. We had a microbiology professor who used to always talk about the Koch postulate, where he says that if you have to blame a bug for an infection, you have to isolate the bug from the infection. You have to be able to induce the infection by injecting the bug, and then you have to isolate the bug at that time. So this slide was an attempt to say, okay, let's apply Koch's postulate to COVID-19. Does it meet that criteria? So this is a kidney biopsy in an early phase of COVID-19. And what you see in the A and C is that in the early phase of infection, there's neutrophilic infiltration of the kidney. So you see the glomeruli and the tubules are side to side. And this neutrophilic infiltration, it actually looks, if you go to D, it looks almost like a pyelonephritis, in the early stages. And then subsequently, like all viral infections, after that, you have an infiltration of T cells, lymphocytes take over. So there's an early neutrophilic infiltration, so it's non-specific. You see red blood cells in the capillary loops. There's obstruction that we talked about as part of the microcirculatory changes versus even in some cases frank thrombosis in that study. Next slide, please. And these biopsies were obtained initially in China at the beginning of the epidemic. And then this is an electron microscope cut of the same kidney biopsy, showing actually that you do have the COVID-19 particles in both the slide A is the interstitium, slide C shows the podocytes, that in both areas, there's evidence of those spiked viral particles in them. Next slide, please. So at least from the standpoint of trying to say, do we meet Coach postulates? We show that in COVID-19, at least, if you biopsy the kidneys that are failing in COVID-19, you will find the particles. We didn't extend it to the point of saying, well, let's take the bugs from the kidney and implant in another animal. So the early phase of the Koch's postulate is met, at least in the early phases, with the kidney biopsies that were done by the Chinese investigators at the early phase of this epidemic. Next slide, please. And those are from Kidney International slides. Same thing, showing different parts of the kidney with the spike particles. Next slide. So I have showed you that there's evidence that the kidneys get involved, and we have provided a molecular biophysical explanation. The high abundance of ACE receptors in the kidney, just like you have large amounts of ACE receptors in the lung, that helps the virus getting both in the lungs and in the kidneys. But because during the pandemic, the past 22 months, we've seen so many studies from Lancet, American Journal of Nephrology, Kidney International, Journal of Clinical Virology. Everybody, as this is going on, people are publishing their observations. But many of these studies have the limitation of, retrospective bias. They're basically looking backwards at what they've seen. And no one can blame them. We're all trying to, drink from a water hose. So much was going on, and I really commend the people who were able to, assemble patients and data and publish fairly quickly, because it helped give everyone else some information that helped us adjust. So you see that the propensity for kidney involvement, one study will say 3%, one says 12%, one says 20%. And it's just because everyone's looking at different things at the same time. Next slide. So the numbers you get in terms of depends also on whether the patients were in the ICU or whether the patients were in the general floor. So the higher numbers are obtained in ICU patients. Next slide, please. So this is the study that I think did the best job. And this is a study from the United Kingdom. Basically, it's a prospective study. So they looked at everybody with COVID-19 from a WHO clinical characterization study. They looked at 254 hospitals in the United Kingdom. They focused on adult patients with COVID-19. And the outcomes they were interested in was biochemical acute kidney injury. So kidney injury diagnosed by high creatinine or reduction in urine volume. And then they applied statistical analysis using logistic regression to look at the results. And basically what they showed was that acute kidney injury in these patients, there were some risk factors. They found out that male patients had a higher risk. If you had pre-existing kidney failure, then you have a higher risk. That's not surprising. That's true for every disease. If you have your kidneys are already damaged, then they're going to be damaged some more. If you're Black, if the patient is Black, they have a 44% higher risk for infection. If you have a respiratory rate greater than 30, that's not surprising because we said it starts in the lung. And the 28-day mortality for different stages of kidney failure are shown in there. Requirement for dialysis increased 3 times if the patients had stage 3 kidney disease versus early phase kidney disease. So this study, to me, I think is the gold standard from nephrology, dialysis, and transplants, the Oxford Journal of Nephrology, because it shows that acute kidney injury is common, is identify the risk factors for mortality, and it shows that the rates of acute kidney injury are also improving with better management. Next slide, please. So why should we even care? We talked a lot about why the kidney gets involved, how it gets involved. This study actually shows that when the kidney is involved, the mortality is much higher. So you can see that percentage of survival drops. The top part of the slide is patients, ICU patients that don't have kidney disease, and the lower graph with the red marker on it are patients who have acute kidney injury on top of COVID. You can see that over, if you follow those patients over 40 to 60 days, mortality is substantially higher in kidney failure patients. Next slide. So what about the antiviral drugs? We looked at the structure of the virus and we talked about the viral RNA polymerase. So several drugs have been designed. We talked about remdesivir, we still use it. In slide B, we have molnupiravir, which is the drug made by Merck, which is now being shown to reduce need for hospital stay by 50%. The other drugs, ribavirin, which we use for Lassa fever, did not work out. Symposium, which we use for hepatitis C, did not work out. Tenofovir, we use for HIV, did not work out. So only remdesivir and molnupiravir, which is the one made by Merck, that they're trying to get approval for. Because if you can reduce need for hospital stay by 50%, that's a big deal. That's even better than remdesivir. So, but we have to wait for the trials and FDA approval, but it's a very promising development. People say it's a wonder drug. I don't know that it's a wonder drug. If all it does, it reduces hospital stay by 50% or need for hospitalization. But that means people can take it at home and avoid deterioration to go to the hospital. It is a big deal, but I wouldn't say it's a wonder drug. The way, we have had other wonder drugs like penicillin. Next slide. So this is some observation that we have observed is seen in taking care of kidney patients. So at the top slide is a chest X-ray showing a catheter that we put in for dialysis. Normally that catheter, if you look at the picture below, you want the tip of the catheter where the superior vena cava meets the right atrium. It just dips in the middle. Because we said it's a lot of thrombosis, we found out that if you leave that catheter in that normal position, you're not gonna get good flow if you're doing dialysis. So now we drop the catheters deeper into the right atrium to mitigate the issue of thrombosis that we talked about that contributes to the pathogenicity of COVID-19, not just in kidney patients, but all COVID patients. Next slide. So vaccination in dialysis patients. So we just showed you that COVID-19 can put people on dialysis, can lead to more mortality when people get it and have kidney failure. As if this were not enough, we found out that a lot of dialysis patients died with COVID because in dialysis, people are sitting close to each other. So there was a high spread. So one of my friends, who's the director of dialysis at Downstate in Brooklyn, they had 600 dialysis patients at the start of the pandemic. After the first 18 months, they were down to 400. So they had lost about 25% of their dialysis patients died from COVID. So this is a vulnerable population. You want to immunize them, but unfortunately, there's impaired humoral and cellular immunity after the Pfizer vaccine. So this is a paper from Journal of Clinical Investigation, July of this year, showing that out of 39 dialysis patients who were given their first dose of the Pfizer vaccine, neutralizing antibodies were found only in 4 patients. So it's almost like 10%. Only one of 39 kidney transplant patients had IgA and IgG antibodies that were neutralized into the virus. So that's the humoral part. So there's impairment of humoral response. There's also an impairment of cellular response in dialysis patients. So the anti-spike protein, CD4 helper cell, and anti-CD8 spike cells were also reduced in dialysis patients, and even more reduced in kidney transplant patients. So these patients have to have the booster. So a lot of kidney patients on dialysis or transplant have to have the booster. Next slide. Next slide. So this is my last slide. It pretty much summarizes what we've said, that kidney disease is common in COVID-19. We think it's common because of the role of the ACE2 receptor in the kidney. There's high concentration of those receptors in the kidney. Kidney damage occurs through direct and indirect effects, those of sepsis, lung injury, inflammation, and direct cytotoxicity. No need to stop ACE inhibitors in those patients because the trials that looked at that didn't show an improvement. Treating patients with kidney disease in COVID, we treat them just the same way we treat other patients, except some of them need dialysis. We use antiviral, monoclonal antibodies. But kidney involvement with COVID-19, if the patient develops acute kidney injury, it carries a poor prognosis. Mortality is 2 to 3 times worse. Thank you so much for inviting me to talk with you. I would be glad to take any questions you might have.
Thank you very much, Dr. Nezuru. It was a very interesting presentation, and I'm very happy that you highlighted that vulnerable dialysis and transplant patient population. It was very interesting. And I'm sure as time goes by, we'll learn more and more about all the more detailed knowledge of what this virus can do to all our organs. Thank you very much.
Thank you.
As we continue in our program for today, at this time, I want to welcome Dr. Adesh Ramsubag. He is a professor in the Department of Life Sciences at the University of the West Indies St. Augustine campus. He works in the field of microbiology and biotechnology. His research includes the application of molecular techniques to characterize microorganisms and microbial community-associated environmental processes. He also looks at infectious diseases and biosynthesis of novel bioactive metabolites. He has co-authored over 65 peer-reviewed journal articles and has participated in over 50 presentations at various conferences. Professor Ramsubag has successfully supervised about 38 graduate-level students in research and has served as a deputy dean of the Faculty of Science and Technology from 2012 to 2015 and as head of the Department of Life Sciences from 2015 to 2018. Additionally, he was the recipient of several prestigious awards. Today, he will help to navigate us through the topic of antimicrobial drug development. Good day to you, sir, and I hand over.
Hi, good day, Wendy. Let me try to share my screen. Okay, I hope you all are seeing.
Yes, we are. You can go ahead.
All right, I'm hearing, I assume. Okay, so thanks very much, Wendy. Thanks to Dr. Unakal and Prof. Akpaka for inviting me to present. And I'll be talking a little bit on something not too close to clinical microbiology based on practice, but I'll be talking about some work that we are doing in life sciences, some colleagues and I, on discovery and development of novel antibiotic adjuvants, as well as novel antimicrobial compounds for treating resistant bacteria. So you all will know very well about the challenge we have with managing antibiotic resistant infections. And basically we have large number of people dying every year from these type of infections. WHO estimates 700,000 deaths annually. And this number is expected to increase significantly by 2050 when 10 million people will die yearly if there is no effective treatment for antibiotic resistant infections. And most of the deaths will be in Asia and Africa. So we really have to find some effective means of moving forward to control and manage antimicrobial infection. And being someone involved in environmental microbiology, I want to take it from a different angle. I think to develop effective strategies for managing antibiotic-resistant infections. We have to look at the evolution, and we know that microbes have been on Earth for almost 4 billion years. So we have had 4 billion years of evolution, and antibiotics and antibiotic resistance are not recent phenomena. These have been occurring for billions of years. And we can look at diversity as a measure of time. So we have had billions of years for these complex mechanisms to evolve. And you have a range of diverse mechanisms as well. And we have to understand that microbes live in very, very dense communities. A single gram of good soil might have billions of cells comprising of a couple thousand species. And dozens may be very active at one time. So you can imagine the type of interaction, the type of competitions that you will have among these microbial communities. And this would have given rise to antibiotics because it's a competitive mechanism. And once you have antibiotics, you will have other organisms countering the antibiotics by developing resistant mechanisms. So we have evidence for at least 2.2 billion years we would have had beta-lactamases present among bacteria. Okay, so by the time you have a new antibiotic in the market, you could be assured that there is already resistance somewhere in the environment, and it is only a matter of time for that resistance to reach clinical strains. Okay, so this is just a little slide on the amount of antibiotic resistant genes. We have had about 1,600 characterized, but one not so recent study estimated 20,000 potential resistant genes from bacterial genomes. And with the level of technology we have now and the new data, I'm pretty sure this is very underestimated. All right, so all of these genes are already there waiting for to enter the clinical isolates. So it is not surprising then that once you had antibiotics introduced in clinical practice, not too long after you will have the occurrence of resistance. Within recent years, the same year of release, you would have had resistance being reported. In fact, if we plow down deeper into this data, you have some resistance being reported even within the same month of release. So we have to recognize that resistance will always be here, and we need to have, some sort of effective pipeline to develop or continuously develop antibiotics or new antibiotics or new antimicrobial strategies that will be one step ahead of resistance getting into the clinical isolates. I don't think we could prevent that, especially in our modern type of human civilization. So we need to have a robust pipeline continuously developing the new antimicrobial compounds. But the problem now is that the pipeline is broken. There are few new antibiotics being developed. The large pharmaceutical companies have now all but abandoned this area of research because it's not economical for them to invest hundreds of millions of dollars, in some cases billions of dollars, and they develop and introduce a new antibiotic, and then within the same month, within the same year, you have resistance now entering into the clinical isolates. So they are not able to recover their investment. Most of the development work taking place right now is from small companies and universities. And focus has been on developing derivatives of existing classes of antibiotics. There are few new classes or new strategies that are being utilized. Okay, but also there is more interest in alternative strategies. So for instance, now a lot of researchers have been focusing on developing adjuvants that potentiate existing antibiotics and make them effective once again against resistant infections. Okay, and antibiotic adjuvants, you have several strategies that you all will be familiar with. They may inhibit the efflux pumps, they inhibit the modifying enzymes like clavulanic acid, for instance, is one of these. they enhance permeability, the increased uptake of antibiotics, as well as they may inhibit signal systems that affect the bacterial resistance mechanisms. So the bacteria may have resistant genes, but if these genes cannot be induced, then they are not able to counter the antibiotics. So we have been working on our antimicrobial discovery program in this department. We have basically been leveraging on the tremendous microbial diversity we have in the tropical Caribbean environment. Okay, we are a biodiversity hotspot, and this hotspot is basically as a result of the macro level flora and fauna, our plants and animals and insects and so on. But if you look at the microbial level, it is even mind-boggling the amount of diversity we have. Okay, extremely high diversity and also extremely unique strains that create a real good potential for drug discovery research. Okay, and to put things in context, I'm showing here some community analysis we did with some average soil. So this is not our exciting sites. Typically, these sites would have like maybe 20, 30 OTUs, and an OTU is like a species level designation. Not exactly, but for this presentation, we could assume that an OTU is like a species. And typically for these unremarkable average sites, you may have 20, 30 OTUs dominating the microbial community. And you may have like a couple thousand OTUs, but most of these will be inactive. You may have 20, 30 being dominant. But we have had some sites in this Caribbean that we have been looking at, and we can't really explain the amount of diversity. When I did a bioinformatic analysis for this graph, I thought I made a mistake, and I was now learning bioinformatics then, and I went to an expert, globally recognized bioinformaticians, and he double-checked, and it wasn't an error. So it shows here when we pull out the top 60 OTUs, and we look at the community structure, these accounted for less than 20% of the microbial communities, which means that in some of these our sites, you may have hundreds of organisms that are all active at the same time. Remember, this is not typical. You will have 20, 30 generally that will be active. High levels of microbes that are active. So you can imagine the competition that is taking place, and the type of chemical signaling among these microbial populations. And a single gram of these soils may have tens of thousands of OTUs. Okay. So again, this is the ideal type of environment for drug discovery because you have potential for many novel metabolites. And when we look at identity of some of these OTUs, so I pull out the top 100 OTUs, the most abundant 100 OTUs, and I identify them. And these pink segments, each segment represents one OTU. And the pink segments are dominating majority of the population comprised of these pink segments, and these are unclassified at the family level. Okay, so I did this for different subgroups of the OTUs, and we are getting the majority of organisms unclassified. At the family level, many are also unclassified at the genus as well as at the phylum level. Now, if you analyze any soil sample, you will tend to get some amount of unclassified bacteria, but I've never seen anything close to what we have been observing in our Caribbean environment. Again, novel species, potential for novel metabolites, and potential for good drug development research. So we have been working on this project for some time. We have been using traditional culture-based methods. So we started with these techniques, simply going in these environments and isolating bacteria and fungi, and then culturing them and assessing their capability of producing antimicrobial compounds. And we have also used metagenomic approaches where we build metagenomic libraries, and we have started to use targeted sequencing approaches as well. So basically with the metagenomic libraries, we would collect samples, extract DNA, And then we will fragment the DNA into smaller pieces and randomly clone these fragments into vectors and then transform the vectors into bacterial cells. And then we screen these clones now. We will generate like millions of bacterial cells and pull out some of these and screen them for antimicrobial activity. And then we'll sequence the inserts. And if there is anything interesting, then we will do further characterization. Okay. With the targeted sequencing approach that we have started, we are sequencing the DNA and identifying interesting clusters, bioactive gene clusters, for instance. And then we will clone these gene clusters, novel ones. We're not going to clone anything that is highly similar to known features already. We are going to clone the novel genes into vectors and express them, and again, look for the novel antimicrobial compounds. Once antimicrobial clone or isolate is identified, then we'll use standard chemistry-based approach to identify and purify the compounds. So for instance, we'll go to batch fermentation, we'll do solvent extraction, then we'll fractionate the crude extracts. Then we'll test the crude extracts for bioactivity, and then also use chromatographic techniques to purify the compounds, okay? And then we will identify the compounds using spectrometric techniques, standard chemistry-based methods. Okay, so far what we have achieved, we have 9 novel or new antimicrobial compounds in several classes. But for us, we are most excited about the discovery of 2 new classes of antibiotic adjuvants. Okay, and we are now focusing on some preclinical research to develop these 2 adjuvants. And we are also working on one of the antibiotic compounds as well. So basically what we will be doing, or what we are doing or have done, we will generate libraries from the natural products. So we do structural modification and derivatization of these compounds. Then we will look at efficacy against different bacteria and microorganisms. We'll look at mechanism of action as well. And then we have been doing in vitro and in vivo assessment of efficacy and safety as well. Okay, so for instance, the 2 adjuvant classes we have found them to potentiate several classes of antibiotics to effectively control many of the WHO priority pathogens. So for instance, one adjuvant class seems to be working better with gram-positive bacteria, which are shaded in green. And the other adjuvant class seems to be working better with the gram-negative bacteria. And they work with against multiple gram-negative or multiple gram-positive bacteria, as you will see shortly. So with the adjuvants research, we have been using this checkerboard assay. Typically, what we will be doing is we use microtiter plates and we introduce antibiotics at decreasing concentration in columns. So as we move from left to right, each column is getting a lower level of antibiotic concentration. And we also will introduce the adjuvant compounds in rows, and the rows get decreasing concentration of adjuvant compounds from top to bottom. Okay, and then we will put our resistant bacteria in each well and observe for growth. And if the adjuvant is having a potentiating effect, we'll see this ladder-like observation where it shows that with the presence of the adjuvant compounds, the MIC of the antibiotic is decreasing. Okay, so this is the typical type of result we will look for potentiated effects. So this is just an example of one of the the screens that we would have done. So we have here the different compounds in class one. And the MIC, in this case of ampicillin against Staphylococcus aureus, MRSA, was very high, 128. In some cases, I think it will be higher than 128. I might have removed the greater than sign in some of these for simplicity. But with the addition of 50 microgram of adjuvant compound 1, 50 microgram per mil, the MIC was reduced from 128 to 4 in the first row. And other compounds have even better results. Similarly, the MIC for vancomycin-resistant Enterococcus reduced from 64 with vancomycin by itself, and few compounds we tested here, for instance, moved from 64 to 4, and then even better with the lower ones. So we are restoring the ability of the antibiotics now to effectively control the pathogens, the resistant pathogens. This is a more detailed screen. This one is against MRSA. I'm using different clinical isolates of MRSA. And we are seeing here ampicillin, the MIC by itself is 250 microgram per mil. And with addition of 16 microgram per mil of the adjuvant compound, the MIC moved to 0.5. Okay, so from 250 to 0.5. So basically, the susceptibility threshold was reestablished. So then ampicillin, which is probably no longer used as much, can now be utilized with the presence of these adjuvant compounds. Okay, and the example was similar with many different antibiotics. And each of these antibiotics was ineffective against the MRSA strain that we used, okay? So again, this shows good potential of the adjuvant compounds. We did some in vivo studies using mice as well. And we infected mice and looked at bacterial levels in the liver and spleen. And we have some controls here, like untreated control and ampicillin by itself, the second bar. And you can see the levels of bacteria in the liver and spleen is very high. But when we combine antibiotic ampicillin with our compound, the levels are very low and equivalent or similar to the positive antibiotic control, which is vancomycin. And vancomycin was effective against the strain. Okay, and the compounds themselves also didn't have strong effect without the antibiotic. So the similar response was seen for both liver and spleen. And this is MRSA. Again, in terms of survival of mice, we did similar experiments. And we see here the vehicle, this is just a formulation agents. After 1 day, all the mice died. Ampicillin by itself, after 1 day, all the mice died. Positive control vancomycin was supposed to be effective against the strain. Most survived over the time of the experiment. But then when we added our compounds to ampicillin at 2 different concentrations, all the mice survived and they were happy till the end of the experiment. Again, with the compounds alone, they had some positive effects, but the mice eventually died. This is a class 2 example. We worked at gram-negative pathogen Klebsiella, and similar results we showed for MRSA, we also obtained for our second adjuvant compound with Klebsiella pneumoniae in mice. Okay, when we added the compound to antibiotic, ciprofloxacin and meropenem, we had very good reduction in bacterial levels and also survival in mice as well. Okay, so it's almost mimicking the first experiment. We looked at some safety profiles of the adjuvant compounds, and they were very positive. They had relatively low hemotoxicity. We look at cell size of toxicity as well, using HUVEC cells. We look at feeding and body weight and the weight of different organs, and even using high concentrations of the adjuvant up to 2,000 milligram per kg. And this is very high because for the efficacy treatment, we were using 10 milligrams per, up to 10 milligrams per kg. And here we are using up to 2,000 milligrams per kg for the safety studies, and weight and feeding and organs and so on were all similar to the controls. All right. So in terms of mechanism, we determined that our compound, this one class that we looked at so far, we haven't looked at the second class, but the first class is a inhibitor of sensor histidine kinases. So these histidine kinases detect sensors like antibiotics, and then they trigger a response to activate the resistant genes. But what our compound does is bind to the catalytic domain of histidine sensor histidine kinase, and hence it prevents the activation of the resistant genes. So it means that the bacteria is disarmed and not able to respond to the antibiotics. Although the resistant genes might be there, it is not, the genes are not activated because the sensing, the signaling system is disrupted. We validated this with some transcriptomic and base analysis. We showed that with the presence of our adjuvant compounds together with ampicillin, you had suppression of many genes involved in resistance, virulence, and global regulation of defense processes as well. So clearly, this organism is disarming the pathogen from being able to respond to the antibiotics. Although they have the arsenal present in their genes, the genes are not expressed. Okay, so we are continuing with research. We are doing further developmental research through now an international GLP lab. We are working towards approval to get an investigational new drug status by the US FDA. Focusing on basic ADMET analysis, using in vitro culture and animal models as well, hoping that eventually we'll get the clinical trial through international partners. Okay. So this is basically it. In conclusion, I just want to emphasize again the tremendous unique microbial diversity we have in the region. And this may translate to great potential for novel metabolites and drug discovery from these metabolites. I didn't talk about the investments and the challenges we have in moving this research forward, but just to mention that we do need significant amount of investments if we are to harness the biological potential to translate into economic development and welfare. Okay, so again, I'd like to say thanks to the organizers, the participants, members of the medical faculty, and just to acknowledge, Yui and my department, chemistry department, and our research team for support for this, research program in the Department of Life Sciences and Chemistry, Faculty of Science and Technology. Okay, so thanks very much, everyone. And I pass you back to the coordinator.
Okay, thank you, Dr. Ramsobag. I must say that was very interesting, and I urge you to push and complete your research. This is very good. The world needs more effective and safe choices for treatment of these microbes who are, continuously drying up the pipeline of agents that we have available. So thank you. Now, at this time, I want to introduce to you Dr. Boris Castillo. He is a medical doctor who graduated from the University of Panama and completed his specialty in internal medicine at the Manuel Amador Guerrero Hospital in Colón City, and then later he specialized in infectious diseases at the Metropolitan Hospital Complex in Panama City. He currently serves as an advisor to the Nosocomial Infections Committee of the hospital complex, and he helps as the coordinator of the Triple Therapy Clinic for patients living with AIDS. He is also a member of the board of directors of the Society of Infectious Diseases in Panama. And today he will take us through this exciting topic of antimicrobial resistance and its implications for the healthcare system.
Okay, good morning. First, I want to thank you for the invitation. It's an honor for me being part of this symposium. Let me share my screen. Okay. Can you hear me and see my screen only to check?
Yes, we can.
Okay. I'm going to talk about the antimicrobial resistance and its implication for the healthcare system. Let me put something here. Okay. And put the... Okay, this is my disclosure. I'm a speaker from some pharmaceutical companies. This is the topics that I'm going to talk. First, the impact of the problems in terms of mortality, cause. We have some examples of real patients from my hospital with diverse resistance mechanisms. And for the last, what can we do? Some topics are about rational use of antibiotics. According to the World Health Organization, the great threats for human health is this problem, the antimicrobial resistance, climate change, poverty. And the prevalence of these multi-drug resistant organisms is continuing to increase and is related to mortality, higher mortality, and significant morbidity. I don't know in Trinidad, but in my country, in Panama, the combination of COVID-19 and resistance is the perfect storm. It could be accelerating these silent pandemics. In this paper of last year's, the co-infection with bacterial infection and fungal infection with SARS-CoV-2, if you see, it's very low, the secondary infection or co-infection, but the most of the patient using antibiotics. And if you see, it's not different, the survivor patient and non-survivors that using antibiotics. So in the first 6 months of pandemics, more than half of the hospitalized COVID patients receive antibiotics. According to CDC, more than 2 million of people in the United States become ill with antibiotic-resistant disease every year. That means 23,000 of deaths every year. And if we don't do nothing, by the year of 2050, like Dr. Adish says, we have a lot of death by antimicrobial resistance, more death than car traffic accidents, more deaths than diabetes, than cancer, than another infectious disease. The antibiotics is made the biggest success in the history of medicine. It helped to reduce global deaths from infectious disease for the last years. But now we have a lot of problems. For example, like Dr. Adish says, the declining of antibacterial approved in the last years. Look at this. This is all the medication approved by FDA, and the blue is non-antibacterials, and the red one, the red is the antibacterial drugs. Only 8% for the last 2 years is for treat infectious disease. Why Big Pharma has abandoned antibiotics? It's very expensive. The developing of new antibiotics, of new mechanisms of action is around $1.5 billion. And the profit, the average revenue generated from antibiotic sale is very low. So the Big Pharma prefer to invest in cancer treatment, high blood pressure, diabetes, dermatology, cardiology, because there's a not economically viable investment because the very expensive these topics. That is the reason that we have a lot of medication for cancer approved in the last years compared to antibiotics. They are more expensive. They have more patients with cancer disease. The other problem, and Dr. Mina talks about it, is the drug resistance follow the drug like a faithful shadow, Paul Ehrlich says. And after years of investigation, billions of dollars, soon as the new introduction of a new antibiotics, we see a paper in a New England Journal on Lancet disease report of resistance to that antibiotics. Remember that the development of resistance to antibiotics is a natural problem, is inevitable. And the trends of global antimicrobial resistance is continue to increase. We can delay their appearance and avoid the spread using isolation, hand washing, and with the help of nosocomial committee infections. The other problem is antibiotics differs from other class of drugs. For example, anti-hypertensive drugs or drugs to diabetes. The way a doctor uses an antibiotics may affect the response in another patient. It's very different, the use of antibiotics. In the hospital, most of the time, like half of the patient, the use of antibiotic is unnecessary or maybe with a suboptimal drugs. For example, the doctor feels under pressure or they are not sure is a bacterial disease or viral disease. The other problem that we have is the use of antibiotics in food animals, not because the animals are sick, it's because to promote growth. I'm gonna introduce you from some example of the more problematic bacteria in my hospital and in the whole world. The first one is Acinetobacter baumannii. Sorry for this slide, is in Spanish. This is a blood cultures of CBC with Acinetobacter baumannii resistant to carbapenem. We only have one option in this culture, but the problem is you cannot use the only option in bloodstream infection because tigecyclina doesn't have a good concentration in blood and in urine. So we only have one option for this patient. This paper is from Brazil. They have outbreaks of resistant carbapenem and Acinetobacter in the intensive care unit of COVID-19. And we have the same problem in Panama. In my hospital, we have intensive care unit for COVID, A, B, C, D, like 8 intensive care unit. The second one, Pseudomonas aeruginosa. The problem is not only in my country. This paper of Lancet Infectious Disease is about the ranking of gram-negative bacteria. The more problematics in terms of treatment, mortality, healthcare, trend of resistance, prevalence, community burden is the same as Panama. Acinetobacter, carbapenem resistant, Pseudomonas, E. coli, and Klebsiella. Look at this patient with urinary tract infection with Pseudomonas, resistant to all antibiotic. Is extremely resistant, and the only option, polymyxin, it doesn't have good penetration in urine. We prefer colistin, and in my country, we don't have colistin. That is different to polymyxin B. It's very important to know the mechanism of resistance, and this patient have a metallo-beta-lactamase called VIM. We have a problem with this patient, and it has an immunosuppressed patient. The only option it could be polymyxin E, is colistin. In my country, in my hospital, the resistance mechanisms from Pseudomonas, the most of the time are not enzymatics. And some patients have carbapenemase, for example, VIN is the most frequent in Pseudomonas. This is very important for the use of the new antibiotics. Ceftolozane, tazobactam is stable against common resistant mechanisms, for example, loss of proteins in the outer membrane, or ANSI, or outflows pumps. So you can use ceftolozane, tazobactam if the Pseudomonas is resistant to meropenem, and the mechanism is different from the production of carbapenemase. In my intensive care unit, the most frequent cause of pneumonia is Pseudomonas and Acinetobacter, and almost the same in Central America and some Caribbean countries. Another paper, gram-negative is the most frequent cause of intensive care unit infection, the same as Panama. The other problem, E. coli, Klebsiella, carbapenem resistant, and spectrum, extended spectrum beta-lactamase. This patient is from the community, ER, urgency. E. coli producing beta-lactamase extended spectrum is resistant to all cephalosporin, but it's resistant to ciprofloxacin and sulfa. We use a lot of carbapenem for this kind of infection because 20% of my E. coli are resistant to cephalosporin. And in Latin America, that is very frequent, the E. coli in intra-abdominal complicated infection, but the most frequent bacteria that produce extended beta-lactamase spectrum is Klebsiella. Look, in my hospital, the evolution of this, 20% in 5 years ago, and the last year is 25%. The consequence of that is we use a lot of carbapenems. And the result of a lot of use of carbapenem is this. It's a bloodstream infection with E. coli, both resistant to meropenem and imipenem. According to CDC, the urgent threats is Acinetobacter, resistant to carbapenem, fungus, Candida auris, and carbapenem-resistant Enterobacteriaceae. Which will be the most effective antibiotic in this patient? For example, empiric treatment. But before answer that, you have to know the mechanism of resistance. It's very important for the doctor to know that. It could be KPC, or it could be a metallo-beta-lactamase, for example, New Delhi, BEAM, or imipenemase. In this patient, we detect New Delhi. It's more frequent in Klebsiella, but in the last month, we start to see this. So we don't use the new ones, ceftazidime, avibactam. We cannot use ceftolozane and tazobactam. And for this patient, we only have, again, one option, polymyxin B. The New Delhi is now in every country. And the problem is worse because the easy travel routes. In one day, you can cross to another continent. And in this paper, the European tourists that traveling to India with no contact with the Indian healthcare system is still test positive for carbapenems producing Enterobacteriaceae after they came back to your country. It's very worried that. And if you have infection with this carbapenems resistant, the mortality is higher. And remember that these genes are mostly plasmid encoded, and this plasmid is highly transferred. It's responsible to outbreaks. This is the same slide from Dr. Mina, that some different bacteria from different species can share the DNA extrachromosomic like plasmid with a lot of gene. For example, carbapenem resistant or beta-lactamide extender spectrum. The mortality is higher when this kind of infection carbapenem resistant. The crude mortality in this infection is more than half of the patient, 2 to 5-fold higher risk of death. That's because empirical ineffective treatment, antibiotic, or delay. Every time that we have this kind of infection, the cost increase because you have to do a screening for other patient, isolation measures, for example, the use of gloves, batas, molecular tests that are very fast, but are very expensive. Remember, the person-to-person transmission is through the hands. The hands are the main route of dissemination. So it's very important, the hand washing. The role of the contaminant environment probably is less important. It's very important for the doctor. They must know the sensitivity profile of the hospital that they work. For example, if the laboratory of microbiology call me and says, you have a gram-positive in a blood cultures. In my hospital, we don't have vancomycin resistant. The green is sensitive, the red are resistant. So we always start vancomycin from empiric treatment because we have a lot of resistance to oxacillin. We don't have methicillin, we have oxacillin, and the 40% of the staph aureus are MRSA. This is very important, but because the infections like skin infection or bacteremia by MRSA has higher case of mortality when we compare to methicillin susceptibility staph aureus. E. coli. Look, the resistance of E. coli to quinolone, ciprofloxacin, is very, very, very high. We don't use empirical urinary tract infection with ciprofloxacin or with levofloxacin. This is very important because in hospitals that use quinolones for prophylaxis before ultrasound white prostata biopsy, they have increasing rates of bloodstream infection of gram negative. And the problem is the same for surgical site infection. For example, abdominal surgery, E. coli, Klebsiella is very frequent, and the most of the time are resistant to the standard prophylactic antibiotics in other countries. Sometimes we have to cancel a surgery in the setting of outbreaks of antibacterial resistant bacteria, and you have to implement control measure, screening, contact isolation that are very expensive. The other problem, very important, the impact of ineffective antibiotic if in the mortality. This paper is in bloodstream infection by gram-negative, for example, E. coli, Klebsiella, Pseudomonas, and if you see the mortality is very higher if you don't use the best treatment or the appropriate or effective antibiotics. So these problems frequently lead to a delay in the beginning of the best treatment or effective antibiotics. In some papers with Klebsiella or E. coli producing beta-lactamide extended spectrum, they say that 3 days after infection was suspected. When we compare in E. coli and Klebsiella that doesn't produce a beta-lactamide extended spectrum is only 11 hours. So it's a different time and different mortality. The other problem are these resistant infectious disease have a longer hospitalization, graded charge, Sometimes you have to change the CVC. Sometimes you have to begin more expensive antibiotic and more toxic antibiotic. So the treatment failures with this kind of infection is as twice from patient without resistant infectious disease. Another paper related to inappropriate or ineffective antibiotic therapy leads to an excess mortality. Look at this. The odds ratio is more than the Apache, is more than the mechanical ventilation, or it's more than septic choke. The inappropriate antibiotic therapy is a high prediction of mortality. And the most important thing that this is a risk factor that you can modify if you know the data epidemiology of your hospital, and if you suspect the risk factor from resistant antibiotics. Again, the multi-drug resistant are the most important predictor of inappropriate antibiotics therapy, more than HIV, the use of prior antibiotics, heart disease, or very high Apache score. Another problem related to the delay of beginning of effective antibiotic treatment. In this paper, each hour of delay contained a survival reduction of 7%. In this paper, they used the time from very low blood pressure and the beginning of the treatment of the antibiotics. So you have to begin very fast, broader spectrum antibiotics, and the most effective antibiotics. The other problem that we don't see is related to the quality of life in critical ill patients. That because it's not only the mortality and is related to the inability rates for a prolonged period post-discharge. This patient cannot return to the work maybe after 3-4 months. So the cause of this problem of resistant antibiotics is not only the healthcare, 20 billion, it's related to the loss of productivity, more than $35 billion related to the patient that cannot return to his work. Another consequence is related to a patient that doesn't have infection with a resistant organism, because the increasing rates of resistance, sometimes the doctor feel more comfortable if the doctor use broader spectrum antibiotics for empirical therapy. And sometimes these antibiotics are more expensive and more toxic. For example, colistin is the only option for Pseudomonas resistant to carbapenem, is the only option for bloodstream infection by Acinetobacter carbapenes resistant. This antibiotic could affect the renal function. And another adverse effect with the use of polymyxin can change the skin color of the patient. So now, what can we do? The rational use of antibiotics. You have to think, is the antibiotic really necessary? It's very important for the hospital to implement the program of antimicrobial stewardship. Remember that not all fevers is infection cause. Sometimes it could be a cancer disease. Sometimes it could be related to a lupus, autoimmune infection. It could be a CVC that you have to change. And remember, not all the fevers are bacterial caused. It could be viral disease, for example, SARS-CoV-2. Remember, don't treat laboratory, treat the patient. And the perfect example for that is the patient with asymptomatic bacteriuria. It's very frequent in my country. A patient go to the hospital with no fever, doesn't have any symptom, but they have a urine tract infection with E. coli and Klebsiella, and that patient doesn't need antibiotics. The other thing is the sample is significant. The perfect example for that is the patient with diabetic foot. Sometimes the doctors or the nurse use a cultured, I don't know, in Trinidad, know this word. The most of the time, when you take a culture of the superficial area or the diabetic foot, we see polymicrobial bacteria. And that confuses the doctor because they don't know to treat or not to treat that cultures. Remember, appropriate treatment antibiotics begins with an appropriate diagnosis. Remember the colonization, the contamination. For example, gram-positive negative coagulasa in blood culture, for example, Staph epidermidis. It could be contamination. Don't start vancomycin. And the other example we see in the intensive care unit, Acinetobacter or Candida fungus in tracheal cultures, and the patient doesn't have fever, doesn't have level fed, doesn't have new infiltrate in the X-ray. It could be colonization. We don't have to treat that patient. This is a patient with liver disease, yes? This is a rectal swab. This patient has two mechanisms of resistance, Nueva Delhi and OXA40A and E. coli. These patients don't need antibiotics. They need only isolation. This is very important. Maybe the only indication for treat that, for example, the hematology oncologic patient, for example, leukemia, lymphoma, before a stem cell transplantation, if the patient is colonized by KPC, New Delhi, E. coli, or Klebsiella, it could be result in the future in an infection in 25%. Sometimes we have to treat before the transplantation. Look at this. This is an intensive care unit of COVID. Patient with very young patient with septic shock. The patient has pneumonia. We have the name of the test is film array from pneumonia. Is multiplex PCR. The patient have Pseudomonas. The patient have Klebsiella. The patient have Acinetobacter, New Delhi, imipenemase. When the intensive care specialists see that, they don't know what to do. Treat all the bacteria. Sometimes these molecular tests confuse the doctors, are very, very sensitive, are very expensive. In some cases, are cost effective, but you have to revisit the patient, the vital signs, the laboratory test, the X-ray, before to make a change in the antibiotics. So please don't treat laboratory, treat the patients. Sometimes you need more than the antibiotics. For example, the focus control in abdominal surgery. Sometimes you have to call the interventional radiology to drainage maybe an abdominal collection or a skin abscess. The antibiotics alone doesn't work. The new antibiotic mantra, shorter is better. 8 days of antibiotics for pneumonia, or nosocomial pneumonia or ventilator-associated pneumonia is effective, and you don't need 2 weeks of antibiotics. 2 weeks is a pressure for the bacterial to produce a new mechanism of resistance. Another thing, after the patient feels better, after the patient doesn't have fever, the white blood cell is going down, and you have the cultures, maybe you can change the antibiotic for another antibiotics that is not broad spectrum antibiotic. For example, stop meropenem or start, for example, ceftriaxona if the E. coli doesn't produce carbapenemase or extended spectrum beta-lactamase. That is very difficult for the intensive care doctors. They think if the meropenem works well, why you can change the antibiotics? They don't know the importance of change of antibiotics or the de-escalation of the antibiotics. And this is more of the response that I put in my intensive care consult. Change antibiotic, stop vancomycin, stop meropenem, start a less spectrum, broader spectrum antibiotics. So it depends of us, not only infectious disease. All the doctors that use antibiotics can help to reduce the problem of resistance. So make antibiotics great again, please. The last slide is some take-home points. Remember that the prevalence of multi-drug resistant organisms is continue to increase, is very high, and is related to mortality, higher mortality, significant morbidity. The antibiotic resistance can result in a delay of effective antibiotic therapy and in ineffective or inappropriate empirical antibiotic treatment. Remember that we don't have antibiotic for this kind of Acinetobacter resistant, for Pseudomonas resistant. We need new antibiotics very urgent. And these antibiotics now are becoming ineffective as drug-resistant species, not only in Panama, in the rest of the country of the world. We have some new antibiotics for KPC. We have ceftazidime, we have merobaborbactam, but we still waiting antibiotics for metallo-beta-lactamase, for example, New Delhi or VIN, that is related to a high mortality. So thanks again for the invitations. It's very honored. I appreciate the invitation.
Thank you very much, Castillo. It was very interesting data and a good reminder to all of us that we need to develop and use our antibiogram data. And if we're not looking for trends, then we won't know what we have and how best to reduce the mortality and morbidity that we see in our patients day to day. So I want to thank you for your presentation, and I want to thank all the speakers as well. It was certainly a feast of knowledge this morning. It was a rich diversity in our menu, and I think we've touched on all the areas where microbes may hide. And now I want to just open the floor up for our Q&A. I don't know if there are any questions there as yet. I know some of them were being answered as we were going along. Let me see here. So these questions would go out to all our panelists for today. I see a question here. I think this would be for Dr. Nezuru. Does metformin have a benefit on ACE2 receptors in the COVID patient? That's a good question.
Dear Chair, our panelist, Dr. Nazure, due to the time difference in Nigeria, currently he is not available, but this question will be passed on to him and we will
answer at his leisure. All right, are there any more questions anybody wanted to pose at this time? All right, some of the questions were being posed as
There
we went
was
on.
also another question for Dr. Nzerua, but I guess that question was answered during his presentation. That question was, how does SARS-CoV-2 affect the kidneys? And there is such a high mortality related to COVID and kidney disease. I think he really spent time to talk about the disease process with the kidney and then making differentiating that from all the other SARS, and then emphasizing that COVID-19 was even the one that was particularly affecting the kidney compared to the others that affected just the respiratory tract and the lungs. And then, of course, he also mentioned that within the last 22 months, he has dealt with a lot of patients who have kidney problems related to SARS compared to his 10 years of practicing, So unfortunately, he's not here to answer that, but all through from slide 1 to the last slide, he really dealt with that question.
Yes, he did. All right, are there any other questions? Okay. If not, then at this time, Dr. Unakal, I hand back over to you. Thank you for having me.
Thank you, Dr. Glendy Reynolds, for your wonderful job. And on behalf of the organizing committee, we extend our heartfelt thank you for your responsibility, and you took care of this session wonderfully. Once again, thank you very much. Dear all, now it is time to have a little break that we are going to meet again sharp after 30 minutes at 1 p.m. after lunch break. After lunch break, we are going to have research presentations from master students and other research students, as well as followed by panel discussion and award announcement for best research presentations. So I thank you all for being with us until now for the first session. And I request everyone to stay on until 1 o'clock. And 1 o'clock, we are going to commence the second session of this symposium. Please stay on and have your lunch, enjoy your lunch. We will see you back after 30 minutes. Thank you very much. Dear presenters of second session, please stay on with us and be ready with your PowerPoints to share on the screen. We will sharply starting by 1 p.m. Thank you.
You have your keys, Felix. Where's your host, Felix?